together, and for the university and Carbone Cancer Center for partnering with us on this important educational symposium. A few housekeeping things. There's plenty of breakfast and beverages throughout the morning. Please feel free to get up when you need to. Bathrooms are near the reception area. We are also hosting a social gathering at the Spring Hill Suites Hotel just a couple miles down the road at 5 o'clock. You can come and join us and get to know each other, learn about each other and your experiences, and there will also be food and beverages provided as well. Many of you don't know about No Stomach for Cancer. Many of you might know about us, but we founded this organization in 2009 in Middleton, just down the road. It was founded by a family who discovered the CDH1 gene mutation in their family and lost multiple relatives to the disease. Over the years, we've expanded and grown to help patients around the globe, fund research around the globe. We're currently funding research in Portugal and New Zealand and at the NIH. And we help patients of all kinds and from every walk of life and every type of stomach cancer, not just the hereditary type, sporadic disease as well. And we are ready to embark on some very exciting things in the world of stomach cancer research. And you'll learn about some of that stuff today, and we'll talk to you more about it at our gathering later as well. But in the room today, we also have two members of our board, Melanie Torborg and Kylan Riley Knapp. Both are, one is a survivor, a CDH1 survivor, and one has lost her husband to CDH1. And I think Kylan would like to talk a little bit about what brought her to the board, possibly Melanie as well. But again, thank you to Emilio Sandwiches for providing sandwiches later. And again, thank you to the university for everything.
Thanks, John. Thanks for putting this on. Good morning, everybody. Thanks for being here. My name is Kylan Riley Knapp. I am the vice chair of the board of No Stomach for Cancer, and I am CDH1 positive. My dad is also CDH1 positive, and we learned about the mutation when 2 of my dad's 4 siblings got stomach cancer and died from stomach cancer at the same time in their respective lives in their late 40s. When it happened to 2 of them, we thought this can't be a coincidence. We did some genetic testing, learned about CDH1, which is a mutation that causes our particular kind of stomach cancer. And we realized that my dad had it. He elected to have his stomach removed and then encouraged me and my 3 siblings to also do some genetic testing. I did. I found out I had CDH1. I also elected to have my stomach removed. And since then, I have had 2 babies. My goal now is to, if they have CDH1, give them an option for saving their lives that is something less drastic than having their stomachs removed. So I spend my time doing lots of things, but among them is trying to raise awareness, raise money, come to events like this, hear from you, learn what you are doing in your world to participate in this important discussion. And I am here today because I want to learn and I want to work with you and brainstorm and solve this problem together so that the next generation can be better off. So thank you so much for being here. I'm looking forward to hearing from the speakers today, the patient perspective, the professional perspective, and I want to talk to you, I want to engage, I want to brainstorm, I want to solve this problem together. So please come talk to me, and thank you again for being here.
Well, good morning. I'm Dan Abbott. I'm one of the surgical oncologists at UW, and just opening from the UW perspective. And number one, thanks, John, for No Stomach for Cancer for all of the advertising and the support and advocacy. It's just critical that we have all these stakeholders. A couple of points I want to make before we start the program today. Number one, probably preaching to the choir, but we all recognize what a terrible disease gastric cancer is, right? It's this kind of tough combination of not a great prognosis, and the treatment for it is really tough. And that's for all sorts of kinds of treatment, whether it's radiation, chemotherapy is tough, the surgery, it has significant risk, and then, of course, significant lifestyle considerations on the back end. And so it's just all really tough. And so the way we make progress with that is investment in research and investment in patient stakeholders and the patient perspective and lifestyle. And so it's just so great to be doing things like this. Number two, and at risk of coming across as an advertisement for UW, I think we would all be in agreement that it is so critical that your care for this really complex disease is done at high volume tertiary care centers, right? And you're going to see a lot of experts today who many of you in the audience I know have face-to-face interactions with. That is the interventional GI folks, the medical oncologists, the surgeons. But there's also a lot of people that you don't necessarily see so prominently that are absolutely critical too, right? It's the radiologists who have expertise in this. It's the nurse navigators who know who to get you in to see in an efficient and effective manner. It's the nurses who are used to taking care of patients who have their stomachs out and what to look for and the warning signs and the recovery. I mean, it is such a massive team effort. And so I hope that we recognize that it's a lot of people behind the scenes that you might not see that make this as successful as we can. And we're really proud of our program at UW. And with Caitlin Kelly coming from California less than a year ago, we are super fortunate to have an expert, if not internationally, certainly nationally known, who brings expertise in minimally invasive stomach surgery, that is with the robot and or laparoscope. And our whole goal is to turn this into a high volume center where we're known for being regional, if not national, experts in gastric cancer. So thank you for all your attendance today and your attention. It's a real privilege to be able to meet with you all. And unless, Caitlin, you have anything else to say, we should really a big round of applause for Caitlin. Who's put so much time and effort into this.
Thank you. Thank you for everyone for coming today. John and I have been working together for a few months now to put together this event. And, stomach cancer obviously is something very important to all of us. It's been the main focus of my practice for about 10 years now. And I was previously at University of California, San Diego, and then just returned to Madison in July of last year. And I found that we have an amazing multidisciplinary team here at UW for stomach cancer, and so was very excited to have the support from No Stomach for Cancer to be able to put this symposium together today. It's a tremendous opportunity for us, and I'm really looking forward to the day and to getting to know all of you, hopefully. Thanks again. So we're a little bit ahead of schedule, but I think that's probably okay because we may have more time for questions and discussion then. So our first session is going to be on stomach cancer diagnosis and prevention. And our moderators here are Dr. Pat Pfau from gastroenterology and also Dr. Mark Benson.
All right. Well, I want to thank Caitlin and John. This actually is a fantastic turnout on a beautiful Saturday morning, actually. And it's a nice thing to get some flow going, to get this going, and hopefully do this on a more frequent basis, and this group meets on a more frequent basis. So the first session we're going to do, is it's always great to start a conference early. We're going to talk about stomach cancer diagnosis and prevention, which in some ways might be the most important talks because we actually want to prevent this disease and rather than just treat it and then deal with that. And we're a number of talks on cancer diagnosis and prevention. The first talk is going to be by Dr. Noelle LeConte, who is Associate Professor of Medicine with the oncology section here. And she's going to be talking on stomach cancer epidemiology in the United States and worldwide. Right, Noelle?
Okay, good morning, everybody. Let me pull up my slides. As was mentioned, I'm a medical oncologist, and I do population health and public health work. So I was asked to speak about epidemiology of stomach cancer or gastric cancer. Happy to take questions as we go, too. These are my disclosures, and I will not be referencing any off-label pharmaceutical use. This is my handy drawing that I drew as I was preparing this talk to ground us in the anatomy. The part to pay attention to is this part right here. So there's a big difference in epidemiology and risk factors for stomach cancers that come from the cardia and then stomach cancers that come from everywhere else. And I will walk you through those, but keep cardia and non-cardia in mind. So just thinking about the different types of stomach cancer, it's not one size fits all. So there's two main histologies, which is to say pathology types, intestinal type and diffuse type. The diffuse type is more likely related to the CDH1 gene that you've heard about. And those tend to present with kind of this difficult to find diffuse spreading cancer that kind of lives under the surface of the lining of the stomach. Those patients are more likely to be younger and female. And then the more common intestinal type is adenocarcinoma, more likely to be older and male patients, and has an association with chronic inflammation as a key risk factor. And in thinking through that type of cancer, there is this cascade that is represented in the squares at the bottom. But you start with some kind of damage. For most patients, it's an infection called H. pylori, which I'm sure we'll go into in more detail. And that turns into chronic inflammation, which then eventually changes those cells slightly, and then they become precancerous and then eventually cancerous. So starting globally, and there are many, many helpful handouts at the table talking about the global burden of this disease, which I really appreciate. I think there is an opportunity in the United States for us to lead the research and make a big global impact and not just a local impact. So stomach cancer is a huge burden globally. There's over 1 million cases a year. It's the 5th most common cancer and now the 4th leading cause of cancer-related mortality. And if you look through the handouts, there's interesting timestamps because you can see how stomach cancer went from 2nd to 3rd to 4th. So we are making progress, but it is a very common disease globally. And that's contrasted with the United States, where it's the 15th most common cancer. However, we are predicting a pretty significant increase on modeling studies by 62% globally, so we can't sort of take our foot off the gas here. And there's a very high burden in Asia, which I'll go through the data for you, also some parts of Eastern Europe and Central America, possibly related to a higher virulence type of H. pylori, meaning a variety of the bacteria that's more likely to give you this cancer. And I did want to pause briefly and talk about Human Development Index, which is not something we use a lot in medicine, but is a index that is used in development, like NGOs and USAID and that kind of thing. And in countries that have high Human Development Index, they have really high incidence of stomach cancer, but the mortality from stomach cancer is very high in places with lower Human Development Index or indices. And this figure shows you where these HDIs are high. So the green countries are those with high HDI, meaning less gastric cancer, more gastric cancer, I apologize, but less death from gastric cancer. And then the red and orange countries are those that have more mortality but lower incidence. This sort of tries to measure not just the economy of the country, but sort of the human factors that are present in that country, including health, education, and standard of living. So it was an interesting thing for me to read about and reflect on as a predictor of health and health outcome. When we break it down by specific countries, so the table or box on the left is both genders or sexes, and then men is in the middle, and then women at the far right. What should stand out to you, first of all, is that I'll have you notice that the men numbers are just about 2 to 3 times higher than the women numbers. This is a cancer that affects men much more commonly. And then what should also stand out to you is that South Korea is the top across all of those. So Korea and Japan, Mongolia, they bear a big burden of this disease. And you can see most of the top 5 are countries in Asia. Kyrgyzstan pops in there in the middle one for men, but really, really high burden globally in Asia. So that brings us to screening. As you probably know, there is no program for screening for this cancer in the United States, but there are programs for screening in Asia. And I wouldn't be a good cancer prevention oncologist if I didn't talk about screening. So screening seems like a good idea on paper, but you actually need to have some things present in the cancer type to make sure that it's going to be successful. So currently we screen for breast, colon, and lung cancer. Prostate cancer is controversial. We also screen for cervical cancer in this country. And the reason we can screen for those cancers is because they have a long period between when it first becomes a cancer to when it becomes incurable. So you have to have a long, what's called asymptomatic phase. And then the tests you use to screen for can't be high risk. And the doctors to my left here do colonoscopies every day, and they're experts at it, but that is a test that, there is a small risk of like a perforation. That's probably the highest risk screening test that we do. And then we have to be able to intervene. So this comes up with pancreas cancer a lot. Sure, you could screen people for it, but there's really no evidence that diagnosing somebody stage 2 versus stage 3 really makes a huge difference in terms of survival. So these are the 3 things that need to be present. And I would argue to you, and I'm intentionally being a little bit provocative, that we may be at that point with stomach cancer. Certainly they are at that point in Asia. So when we look in South Korea, I'll just orient you. These are survival curves, and the red line is the group that got screened, and the black line is the group that didn't get screened. And on a survival curve, you want to be the higher curve, right? That means more people are surviving. And so in Korea, they do anyone 40 or above every other year, upper endoscopy or EGD, or you can do an upper GI X-ray where you swallow barium in this case, and then they look for any defects in the stomach lining. And so this is just one composite study of screening, but basically every screening trial that's been done in Korea has been successful in helping patients live longer with stomach cancer. Pivoting a little bit to look at overall mortality, I showed you some incidence numbers earlier, but if we look at mortality, what should stand out to you here is Mongolia, where the incidence and the mortality are almost, not quite, but close to 1-to-1. Versus countries like Korea and Japan, where, again, they do screening, and you can see their mortality is very, very low. So they're still diagnosing a lot of people, but they're also potentially curing those people with the screening. Versus Mongolia, where they don't really have great infrastructure and they don't have a national screening program. And just another map, if you're a map person. So the blue is how common stomach cancer is, and then the red is the mortality. And what jumps out to me here, in addition to what we've discussed already in Asia, is Russia. So another area for us to keep our eye on. So pivoting to the United States, as you've heard, in the United States, mostly because we're treating H. pylori, the number of new cases and deaths have gone down pretty regularly, and it comes out to about a 1.46% decrease per year, which is a great success. When we look at what stage people are diagnosed in the United States, just to match this up to what you might consider like stage 1, 2, 3, 4, localized would be stage 1 or some 2s. Regional means that it's spread to the lymph nodes, so that's stage 3 generally. And then distant is stage 4, meaning it's spread beyond the stomach and the immediate lymph nodes around the stomach. And then that unknown stage, you always see this in these type of data analyses, and that's usually people who are diagnosed at autopsy most commonly. So probably not a cancer that was a major player in their symptoms or their health overall. So what we do see is that distant percent, 37%, we would like to shift those ideally into localized, but localized or regional would be great because those are the 2 curable categories. And the reason to do that is because if you're localized, you have the highest chance of cure. We use 5-year survival as a proxy for cure. We can discuss whether that makes sense, but generally it does for cancer. And you can see with each increase in stage, the cure rate goes down. And then if we break it by race and ethnicity, there are some important trends here. One is that non-Hispanic white people have the lowest rates of stomach cancer. And you see, again, particularly high rates in Asian and Pacific Islanders. But also, I would point out Native American and non-Hispanic Black here as well. The Hispanic numbers, there's a very high rate of that CDH1 gene in those communities. So that's partially what we might be seeing there too. And again, males much more than females. So some notable subgroup trends. I'll have you think back to that very crude drawing that I showed you on the second slide. So the amount of people with non-cardia gastric cancer, especially young people, has been increasing pretty steadily for reasons we really don't understand. But it does, as a GI oncologist, it does make me think about rectal cancer, where we're seeing similar trends. And rectal cancer, we think it's an environmental exposure, which I'll go through in another slide. And then we are seeing more advanced stage gastric cancer in people of Hispanic ethnicity for unclear reasons. So I did pull some Wisconsin numbers just for funsies here. So this was done with Dr. Thomas Lawler, who's a data scientist at the Carbone Cancer Center. And this comes from the Wisconsin Cancer Registry System, which is our state registry. And just to orient you to the slides, so the gray line at the top is all the other categories combined. So you can probably ignore that line because it's much more interesting to look at the other lines. So the orange line is gastric cancer. And then the yellow line is gastric cardia. I apologize, I misspelled gastric on that. And then blue is just straight esophageal. So it's tough when you sort of squint at it to make any clear trends, but overall numbers are stable to increasing, I would say. And certainly not decreasing in any serious fashion, unlike the national trends. And then when we look at mortality similarly, maybe we're starting to see a little clip down in the last couple of years, and we hope that will go down quite a bit because immunotherapy, which I'm sure you'll hear about in later slides, has made a big splash in gastric cancer. Okay, so why do we see all these differences, both globally in the US, men, women, different countries? The clearest answer is H. pylori, that there's maybe different strains of it in different countries that affect your cancer risk differently. Clearly, this is a major risk factor for non-cardiac gastric cancers. And clearly, we need to be looking for this, and then when we find it, we need to be treating it. But there are other risk factors present on some of the handouts that are at the table. The ones to target would be those we can modify, right? So you can't modify if you have the CDH1 gene, but you can modify if you smoke, or if you have a diet higher in salts, pickled foods, and processed meats. Other possible risk factors are Epstein-Barr virus, which there's a whole session about by a virologist later today, which I would encourage you to stick around for. Alcohol use, and then autoimmune gastritis, which is an uncommon condition, but probably would push you into wanting to get regular scopes. There is some interesting work around protective factors. One would be an aspirin a day. Other non-steroidal anti-inflammatories may also be helpful. But pretty compelling data that diets higher in fruits and vegetables, and particularly white vegetables, which is not something you hear doctors talk. Usually we talk about white food like it's kind of the bad guy, like white rice, white bread. But here, there's pretty good studies as far as diet studies go, which are always challenging, that diets higher in these white vegetables are actually beneficial. And I listed for you in that little explosion thing what white vegetables are. They're potatoes, cauliflower, turnips, onions, parsnips, mushrooms, white corn, and kohlrabi. So it is intriguing. I think if you eat those foods, you should continue to eat those foods. Statins, which we use for cholesterol, may be helpful. And then microbiome is having an emerging amount of research. So maybe the bacteria we have living in our gut somehow affects our risk for stomach cancer. And then again, I'm going to put in the plug provocatively that I think screening is probably something we need to be more seriously thinking about here, but also H. pylori eradication and retesting. So that was, I think I'm on time. I hope I'm on time. So there's lots of different patterns of stomach cancer across the globe that we should be aware of, especially as people immigrate to the United States and may have different exposure patterns. We really need to be asking people if they've ever been screened for H. pylori, and if they've been positive, were they treated? And there may be a role for endoscopic screening especially in high incidence countries, to decrease the burden of this cancer. Thank you. Did you want me to take questions? Or?
Do you want to take questions right now, or then? I think you have 18
I'm ahead of schedule.
You're 18 minutes schedule. Let's take questions.
All right, cool.
I wanted to hear more about screening, and
Uh-huh.
you mentioned something about taking a pill and it's eliminating cancer. Did I get that right? I'm wondering if that would help with the diffuse type cancer, if that just helps with like the mass.
Well, these are the guys that do the screening, so we should.
Interestingly enough, so there's like two types of like diffuse cell cancer that's the lining of the stomach, and then there's cancers that arise from the actual surface of the stomach lining. So those are the ones that we can see. Hereditary diffuse cancer is often sometimes difficult for us to see with the scope. So what you're referring to is like a camera that you can swallow. So sometimes we have people who will swallow small cameras that take several pictures. So you can swallow a pill that has a little camera on it that takes pictures of the lining of the stomach. It can't biopsy the stomach, and it doesn't often highlight the cellular mucosa, the cellular abnormalities that you would see that you would need to screen, unfortunately.
In other, like in Asia, they sometimes will do small scopes, unsedated. Unsedated small scopes to look, and you can biopsy. Americans are a little bit more wimpy. They don't like doing anything unsedated, actually. So, but there are studies in America where people have put scopes either through the nose, down the stomach, or just for screening for looks and biopsies. Not as much in the United States, though. And I think we really don't do the pill camera much at all. It's not as good for the stomach as other parts of the gut.
So Noel, I just have a quick question for you. You know, we break up the gastric cancer into non-cardiac versus cardiac cancer. And so the gastric cardia is the very top part of the stomach. So do you know why we make that dichotomy, and like, does it change the overall prognosis for people if you have like a cardiac cancer versus a gastric body cancer?
Yeah, I mean, the reason why is mostly in terms of epidemiology and risk factors. Those non-cardia ones are more likely to be that CDH1 related. We tend to treat the cardio ones, especially if they're really high up, more like esophageal cancers, and functionally we tend to use more radiation in that space than chemotherapy. But I think it's more for thinking about risk factors, epidemiology, trends like that. Great, thank you.
So it's my pleasure to introduce the next speaker. It's Dr. Jennifer Weiss. She is one of my colleagues in the Division of Gastroenterology and Hepatology. She's the medical director for our GI genetics program. And she is going to be talking about genetic considerations in stomach cancer.
Thanks, Mark. So actually, the question about whether that camera will work will come up a little bit in this talk, because I'm actually going to show you some pictures of why the camera might work potentially in some instances, or why things look different with different types of genetic cancers. And I also feel like I'm going to have to go home with my tail between my legs to apologize to my husband when I complain when he cooks parsnips and turnips. So yes, we're part of the CSA, so we get a lot of parsnips and turnips, and every time he makes them, I groan. But now I'm going to have to go home and apologize. So in this talk, I'm going to go over just a very brief introduction about genetics and kind of gastric cancer risk groups. Talk about hereditary diffuse gastric cancer syndrome, which I know I'm preaching to the choir to a lot of people in this room. And to be honest, the handout that is on the table in the outside about HDGC is fantastic and covers even more in detail what I'm going to talk about. And I just was like, phew, I have all the same information in my slides, some of my slides that are in that handout. So I'm up to date. And then I'm also going to talk about a couple other briefly hereditary syndromes that are related to gastric cancer, Lynch syndrome, and some of the polyposis syndromes, and then give you some take-home points. So when I think about gastric cancer in my clinic, which is the GI genetics clinic, I always talk to people about gastric cancer risk groups. And so I put people in kind of three big buckets. One is, do I think the gastric cancer in your family or in you is sporadic or random? And these are cancers that are likely due to several factors, largely environmental, things that Dr. LeConte spoke about, and also some things that Dr. Benson is going to talk about coming up in the next talk. There's also risks just with age as you get older, and this is the vast majority of gastric cancers that we just diagnose. Then there is a group of kind of familial clustering of gastric cancers. So these are usually multifactorial. You see more gastric cancers in a family than you would expect, but it's usually due to several factors. So multiple low-risk genes that we may or may not even have identified yet to be able to test for, that act in combination with each other or also interact with environmental or lifestyle factors that are shared amongst family members. So potentially families that do eat a lot of red and processed meats or cured meats or pickled foods, plus they have multiple mutations in low-risk genes that we don't even know how to test for yet. And then there's the very small group of hereditary gastric cancers that are due to a harmful mutation in a single cancer susceptibility gene. So this is like what we call the Mendelian inheritance. So I don't know if you guys remember being in like middle school and doing the yellow peas and the green peas in your science class and crossing them and figuring out which ones are good, which progeny are going to have yellow or green. Like this is what we're talking about with the hereditary groups. And these are families where a family member who carries that harmful mutation in that single gene are predisposed to a higher risk for cancer than observed in the general population. So I often draw out this like pie chart for my patients, and it really is similar for every different type of cancer. So the vast majority of gastric cancers, same with colon cancer, are in that big red sporadic or random group and due to non-genetic risk factors, the H. pylori bacteria, obesity, reflux, diet, age, things like that. Then there's that clustering in orange of the familial gastric cancers. And I do think we are slowly chopping away at that piece of the pie in being able to identify the genes that are involved and start to include them in the yellow piece of the pie. But right now, what I'm going to talk about today is the yellow piece of the pie, which is the known hereditary genetic syndromes that are related to gastric cancer. So HDGC, which is the hereditary diffuse gastric cancer syndrome, Lynch syndrome, and some of the polyposis syndromes. So when do you even start to consider that you have a hereditary cancer syndrome in your family? These are just some major key points that the National Society for Genetic Counselors has on their website, and it's some of the things that we look for in our clinic. So if there are several family members that are related by blood, so have to be on the same side of the family, that have the same cancers or related forms of cancers, and you see it in multiple generations. So your grandfather has a cancer, and then an aunt and uncle have a cancer, and then your cousins have a cancer. We start to think that there's something going on in that family. We worry if cancers are occurring at younger ages than you would expect. So a stomach cancer in someone in their 30s or 40s is unexpected. So that's something that we would start to be concerned about. Do people have bilateral or multiple primary tumors? So does somebody have bilateral breast cancer and a stomach cancer in one person? That's something we would be concerned about. And rare cancers or cancers that are seen in the less commonly affected sex. So if you have a family history of a male breast cancer, that is very suspicious to us that it could be related to a BRCA1 or BRCA2 gene mutation. And then if there's a lack of environmental risk factors, but tons of cancers in the family, you start to think more that it's genetic related and less environmental or shared kind of lifestyle factors. These slides are just to, again, show you autosomal dominant versus autosomal recessive inheritance, kind of going back to the yellow and green peas. So if you have an autosomal dominant inherited disorder, you only need one copy of that harmful mutation to show clinically the risks and the phenotype of that syndrome. And so if your mom is affected or if your dad is affected, doesn't matter. All kids have a 50-50 chance of inheriting that genetic mutation. Autosomal recessive, on the other hand, the parents are the carriers. So they just have one harmful mutation, but it actually takes two copies of that harmful mutation to cause the symptoms. So if it's an autosomal recessive syndrome like cystic fibrosis, you can be a carrier of the cystic fibrosis gene, but your child, in order to have cystic fibrosis, has to have a copy of that gene from the mom and the dad. So if you're just a carrier, you're not you're not at as high risk as someone who has both copies of that gene. The syndromes I'm going to talk about today are all autosomal dominant inheritance. So hereditary diffuse gastric cancer, we already kind of went over the two types of gastric cancer, so the intestinal type and the diffuse type. The intestinal type are cells that are organized into glands, and they commonly present as a mass with kind of heaped up margins or an ulceration. I'll show pictures of that in a couple slides. But what we're talking about with diffuse gastric cancer is cell clusters that kind of lack cohesion. And this is due to the CDH1 gene mutation and the function of the protein from that gene. It includes signet ring cell carcinoma, and then you might hear this term Leonidas plastica, which is a description of what the stomach can look like in hereditary diffuse gastric cancer when there is multiple clusters of these signet ring cells that are turning into small foci of cancer. And it gets kind of a leather bottle appearance and doesn't expand as well as a normal stomach should, which goes along with sometimes the symptoms that you might look for if you have HDGC and where you're getting concerned. So in general, the stomach expands every time you eat, and it gives you room to eat a meal and to feel okay. But if it's starting to get thick and fibrotic or stiff, it's not going to expand as much after each meal. So you might start to feel more full after the same amount of food each time, or you might have nausea or vomiting. These are things that we are looking for. And when we do a scope, we're looking to see if the stomach will insufflate and blow up like we normally see it when we put air in it. And then as we suck it back down, does it come back down easily? And if it doesn't, that could be a sign that things are stiff and that there's potentially cancers in the wall of the stomach. So HDGC is an autosomal dominant inheritance pattern, as we discussed. It is due to mutations in the CDH1 gene in up to 50% of cases. And this gene encodes a protein called E-cadherin that actually plays a critical role in that cell-cell membrane adhesion. And so that's why you get those clusters of cells that are not really cohesive and are not really linking together. The one thing I want to point out is that the CDH1 gene mutation is found in up to 50% of cases. That means that 50% of cases we don't find a mutation in the CDH1 gene. We are starting to identify mutations in another gene called CTNNA1, which also seems to be a little more common in Hispanic populations. But there's still people who fit criteria for this syndrome and do not have an identifiable mutation at this point. And it could be because our technology is just not good enough to pick up every single mutation in the CDH1 gene, or we may just not know all of the genes that are involved in a similar phenotype at this point. There is a significantly increased risk of diffuse gastric cancer, and you'll see lots of different numbers being thrown out. At this point, trying to put together a bunch of studies, the risk is about 33 to 70% by age 80. However, we are starting to find that risk may be a little bit overestimated in some families because, interestingly, so the CDH1 gene, as it says on the next bullet, are related to lobular breast cancer as well. And so it is part of a panel of genes that we do for individuals who have a lot of breast cancer in the family or might have breast cancer, but there might be no gastric cancer in the family. And so we're identifying mutations in the CDH1 gene just based off of these panels of genes that we're testing for in families that might not fit the clinical criteria for hereditary diffuse gastric cancer. So we're starting to recognize that there might be particular mutations in the CDH1 gene, particular families where the gastric cancer is just not a prominent feature. So we think that the risk might be a little bit lower, but I'll show you some criteria of when we start to get concerned. So when should you suspect this? And these criteria are actually on the handout that is available on the back slide. And they are from the most recent guidelines on hereditary diffuse gastric cancer. And we have a celebrity, Karen Schreiber, who has been part of the guideline committee. So this is broken up into family criteria. Family members who I talk about here must be first or second degree relatives of each other. So this is parents, siblings, aunts, uncles. And that's what we kind of talk about with first degree and second degree grandparents. So you have to have at least 2 cases of gastric cancer at any age with 1 confirmed diffuse type gastric cancer. So we care about the pathology. We want to know what the pathology showed from your relative's gastric cancer. If you have 1 or more case of diffuse gastric cancer at any age in your family, and also a case of the lobular breast cancer, which is a particular type of breast cancer in people less than 70 years of age, we get concerned about hereditary diffuse gastric cancer. And if there's 2 or more cases of lobular breast cancer in family members diagnosed age less than 50, you meet criteria for genetic testing for this. On an individual basis, if you have been diagnosed with diffuse type gastric cancer at an age less than 50, you meet criteria for genetic testing. If you have diffuse gastric cancer at any age and Maori ethnicity, and I know I didn't spell that totally correctly with the little symbol, but I wasn't sure how to do that on PowerPoint. But this is because the CDH1 gene mutation was first discovered in Maori families in New Zealand that had a significant risk of diffuse gastric cancer. If you have diffuse type gastric cancer at any age and a personal or family history of a first degree relative with a cleft lip or cleft palate, we get concerned. This gene is also related to the development of cleft lip and cleft palate. If there's diffuse type gastric cancer that you have, and you also have a personal history of lobular breast cancer at an age less than 70, you meet criteria for genetic testing. And if you have bilateral lobular breast cancer before age 70, so even if it's at asynchronous times, if you first have a lobular breast cancer in one breast and then later on develop a second primary lobular breast cancer in the other breast, that is a concern for us. And then if on just regular endoscopy, for whatever reason, maybe you're having abdominal pain or reflux symptoms, that we take a biopsy and we find in situ signet ring cells, and you're less than 50 years old, you meet criteria for genetic testing. But again, 50% of patients who meet the previous criteria will not have a CDH1 or CTNNA1 gene mutation, but we still consider you to have a clinical diagnosis of hereditary diffuse gastric cancer and would still treat you at the same way. And I know I'm probably taking way too long, but thank God we started early because I could talk forever about this. So, okay, 20 more minutes. Okay, so I'm going to get into some pictures that might help explain a little bit more about why this is difficult to screen for and survey for and what we do and why we have the recommendations we have. So endoscopically with hereditary diffuse gastric cancer, so that's the scope that we put through the mouth into the stomach, and then you're sedated. We look through the scope. We can take biopsies. We recommend doing this every year if you're going to go the route of endoscopic surveillance. And the next slide, I'll talk about surgery recommendations. If we are doing endoscopic surveillance, we do something called the Cambridge Protocol biopsies, which are at least 28 to 30 tiny random biopsies that we take throughout the lining of the stomach. But then we also should take targeted biopsies in areas that have white patches and erosions. And this, you'll see the pictures. I'm not sure if it comes across that well, but they're a little bit bluish in tone, and that's because we have a special filter on the lens that we can change to use either white light or what we call narrowband imaging. And then these pictures are taken with narrowband imaging, and they help kind of highlight these very flat white patch here or a small erosion. Now, this is very subtle. So it is, and I like to say, many endoscopists will not actually recognize these subtle lesions as potential areas where there are small foci of signet ring cells, because we can see these kinds of things all the time in people who have no hereditary diffuse gastric cancer. To be honest, I have seen white patches just develop because I've taken biopsies in that area previously. So a year later, I'm doing an upper endoscopy and there's white patches all over the stomach, and I take more biopsies there, and all it is the spot where I took a biopsy previously. So it's very, very hard for us to diagnose an early hereditary diffuse gastric cancer with a scope. In addition, the biopsies are mucosally based. They're very, very superficial. So we can't get very deep into the wall of the stomach, and that's where these foci of signet ring cells are. Also, there are small foci of signet ring cells all over the stomach. So we could take a biopsy in one area and miss a foci of signet ring cells in another area. And there are studies that show that 40 to 60% of individuals will have signet ring cells on biopsies when we take these random biopsies, but it's an even higher rate of individuals who have signet ring cells and foci of early signet ring cell cancers on a surgical specimen when they have the stomachs removed. So surgically, because it's so difficult for us to really keep track and try to survey endoscopically, we do recommend prophylactic total gastrectomy for all individuals with a CDH1 gene mutation that have a family history of the diffuse gastric cancer. And there has been a recent study that came out of the NIH that gives a little more nuanced approach to what we might be able to do to try to identify individuals at an early stage endoscopically if you defer total gastrectomy, but that's something that's very new, and it gives us a little more leeway. The prophylactic total gastrectomy is generally recommended between the ages of 20 to 30 years just because of the early onset of the hereditary diffuse gastric cancer in individuals with the CDH1 gene mutation and family history of gastric cancer. We do not generally recommend it in individuals who are over 70 years old. However, I do have some patients who have had successful surgeries in their early 70s, very healthy, and are doing very well. So it really is on an individual basis with a discussion with you and your surgeon and your primary care provider to decide if that is the right thing to do. And I do really, really recommend, as Dr. Abbott had said, that surgery should be done at centers that have expertise in surgery as well as pathology. And the reason why is because the pathologists, when they get the surgical specimen, they really should be doing very specific site mapping of the stomach, taking very thin cuts of the entire stomach and looking for those signet ring cells in each slice of the stomach that they're looking for. And other centers where they're not used to seeing this, they might not do that. They might just take a superficial look at the whole stomach or take representative slices and look at it. Other management considerations with HGGC is a referral to a high-risk breast center because of the increased risk for women with lobular breast cancer screening. And then there's a really kind of controversial area right now with what do we do with families that have only lobular breast cancer, and that's how that CDH1 gene mutation was diagnosed, but there's no family history of stomach cancer. So for a while, we were saying, well, it's a CDH1 gene mutation, very high risk of diffuse gastric cancer, just send them for the prophylactic total gastrectomy. Now that there's more data coming out, more people being identified who have a CDH1 gene mutation and their families are being followed and no one develops the gastric cancer, we're starting to be a little more conservative and favoring annual endoscopy surveillance in those families and then sending to prophylactic total gastrectomy if we find any signet ring cells on any biopsies. I also always offer a referral to surgery as well to discuss the potential for prophylactic total gastrectomy at any point in their future if they're interested. All right, so that was HGGC. I'm going to go on to briefly talk about Lynch syndrome and polyposis syndromes. So Lynch syndrome is an autosomal dominant syndrome that is due to mutations in the DNA mismatch repair proteins, MLH1, MSH2, MSH6, and EpCAM, and PMS2. And EpCAM is linked into MSH2 because it's a gene that just comes right before MSH2 in the chromosome. And so if you have an issue with the EpCAM gene, it normally causes a problem with the MSH2 gene or involves it. The Lynch syndrome is primarily characterized by early onset colorectal cancer, and uterine cancer is also a very big risk for it. However, there are a number of other cancers associated with Lynch syndrome, and gastric cancer is one of them, which is why it's in this talk. This slide, I'm really just focusing on the gastric cancer risk. So when I think about Lynch syndrome, the way I think about it is the DNA mismatch repair proteins act like spell check in your body. And so as your cells are multiplying or dividing and things are happening, mistakes can happen. Just like if you're writing a paper, you're copying and pasting things all over the place. These proteins go through and pick up those mistakes. But if you're born with a harmful mutation in one of these genes and less of that total percent of functioning proteins, mistakes might be missed. And then they might be propagated onto future cell lines and potentially turn into a cancer. So you want all of these proteins functioning, and if you have Lynch syndrome, you're born at a slightly disadvantage. And then something else happens that knocks out the other partner protein, and you can have a cancer develop. So something like an exposure to an environmental toxin, or just age, the aging process, or something like that. The gastric cancer risks in Lynch syndrome are much, much lower than hereditary diffuse gastric cancer. So, and the interesting thing is they do kind of vary a little bit by gene that's involved with Lynch syndrome. So the overall risk is about 1% to 8 to 9%. The general population lifetime risk by age 80, and Noel, please correct me if I'm wrong, is about 1%. So to put that in perspective, with Lynch syndrome, there is a slightly increased risk of stomach cancer, but it's not like the risk of colon cancer with Lynch syndrome, which can be up to 30, 40, 50%. So with Lynch syndrome, we do recommend regular upper endoscopy surveillance. There are different recommendations depending on the gene that's involved. So it is helpful for us to know what gene is involved in your family. And the reason why we do this every 2 to 4 years, and not every year like with hereditary diffuse gastric cancer, is because we are looking for this intestinal type gastric cancer in Lynch syndrome, which commonly presents as a mass or an ulcerated heaped up, an ulceration with heaped up borders. So just to show the pictures, this is way more easy for us to see and to look at, and it's usually a singular mass, not multiple areas all over the stomach, compared to hereditary diffuse gastric cancer, where we're really just looking for a needle in a haystack a lot of times with the endoscopic surveillance. With Lynch syndrome, I do personally recommend, if you're getting colonoscopies every year, that we do an upper endoscopy every other year. Or if you're getting colonoscopies every 2 years, we do an upper endoscopy every 4 years. So just with every other colonoscopy, it's just easy to remember to get that upper endoscopy to look for this. We also do recommend getting biopsies for H. pylori on your first baseline upper endoscopy, and then treating that and eradicating it, because H. pylori bacteria is a WHO, a World Health Organization carcinogen. And then the polyposis syndrome. So this is something that a lot of people don't think about with respect to gastric cancer. So these are syndromes that are mainly characterized by colon polyps. So tons and tons of colon polyps. Familial adenomatous polyposis, extremely rare, but hundreds to thousands of colon polyps. There is also, and this is due to autosomal dominant mutations in the APC gene. AFAP stands for attenuated familial adenomatous polyposis, and it's attenuated because there's less colon polyps and it starts later in life, but it's still due to a mutation in the APC gene. Just different parts of the gene are involved. And then there's GAPS, which is the gastric adenocarcinoma and proximal polyposis syndrome, which is due to a mutation in a specific part of the APC gene. Interestingly, so these are, and I'll show you pictures. These are polyps that happen inside the colon, but they also can get polyps in their stomach. Slightly different kinds of polyps than in the colon. With GAPS, they don't really have polyps in their colon. They just have tons of polyps in the stomach. So it's important for us to know where the genetic mutation is. With attenuated FAP and FAP, we recommend upper endoscopies every 1 to 4 years, depending on what we find each time. And this is where it really plays, it's really important to have these scopes done at a center with expertise and people like my colleagues sitting here at the table who do these procedures all the time. And you have a continuous relationship with the person who's doing that upper endoscopy that can look for subtle changes in the polyps as they get bigger or as they might change between scopes. There are also other polyposis syndromes called hamartomatous polyposis syndrome, so slightly different type of polyp, again, usually in the colon, different parts of the GI tract, but can still involve the stomach. And I'll show some pictures of those too. So juvenile polyposis syndrome is, these are all, again, autosomal dominant inheritance. It's due to a mutation in the BMPR1A gene or the SMAD4 gene, with a risk of up to 20% up to age 80 for a lifetime risk of gastric cancer. Although we do know that this risk is likely a lot, mostly due to people with a SMAD4 gene mutation. So the SMAD4 gene mutation causes higher association of gastric polyps and gastric cancer. For these individuals, we recommend upper endoscopy every 1 to 3 years, starting at age 18. And then Peutz-Jeghers syndrome, which is due to an autosomal dominant condition from a STK11 gene mutation, has up to about a 30% risk of stomach cancer. and we recommend an upper endoscopy every 2 to 3 years starting at age 18. And what we're looking for in these individuals is, we're looking for polyps. So this is a picture of a normal stomach. And these are pictures of individuals with these polyposis syndromes. So you can, and these are, I will say, on the end of the bell curve that are probably some of the most polyps we've seen. So this is not typical, but I wanted to be able to show you guys what we're looking for and how difficult it is to sometimes tell the difference of a polyp that is a completely benign fundic gland polyp that we see in the stomach all the time, potentially from proton pump inhibitor use. So Prilosec, those kinds of medications can actually cause fundic gland polyps in the stomach that are benign. But it's hard to sometimes tell the difference between these benign polyps and the polyps that are precancerous or have dysplasia and are starting to turn into cancer. And so these are two pictures of people that Dr. Pfau has scoped for me. And you can see it's very difficult to tell the difference between these tiny fundic gland polyps that are likely not precancerous, and then there's a mound of polyps that have precancerous changes that need to be removed. This is a patient with a SMAD4 gene mutation, has tons of polyps in their stomach. So sometimes we do recommend a total gastrectomy in these individuals if we really can't adequately monitor the polyps and get the polyps out that are precancerous. But other times we can do, I'm a general endoscopist, so I don't do the advanced cases. I mean, Dr. Pfau and Dr. Benson will do what's called an endoscopic mucosal resection and take out just the large mound of polyps and then keep going back and looking for any changes over time. But with these individuals, the polyps are typically in the fundus, in the top part of the stomach. So if there is a cancer that develops there, they don't necessarily need a total gastrectomy. But you can see that you really do need to go to a center that has expertise in these syndromes. So my take-home points are gastric cancer risks vary depending on the genetic syndrome. Endoscopic surveillance for diffuse type gastric cancer does have significant limitations because of how subtle the lesions are. We do recommend a prophylactic total gastrectomy for all CDH1 mutation carriers in a family with confirmed diffuse gastric cancer. That at this point, the guidelines can change over time as we develop more better techniques and better surveillance, but this is what we recommend right now. In Lynch syndrome, the gastric cancer risk does vary depending on the gene that's involved, so it is important for us to know which gene you have a mutation in your family. And the gastric cancer surveillance in polyposis syndromes requires careful attention to subtle changes in the polyp growth and appearance. And so in order to do this, you really do need to be going to a center with expertise and potential, and somewhere where we're going to take multiple pictures, we're going to be able to compare changes over time. And again, for all of these syndromes, we recommend management at a center with expertise with good multidisciplinary relationships like all the people that you see talking here today. Thank you.
So, can you hear me?
Yeah.
That was the most thorough and enlightening presentation I think we've ever had on the genetic side of things. Thank you so much.
And thank you, Noel, for starting early because I would not have been able to just get all that in.
Yeah, that's great. So it's raised a lot of questions because you were so in depth. So we're going to ask a couple of these questions right now and need some feedback for the multidisciplinary team here. So what about the variants that have one documented case of HDGC that are in advanced stage? We have that question. And I'll throw the second question right away. How far back through the family tree should a CDH1 patient go?
So personally, at a minimum, we try to collect a 3-generation pedigree. But I like to go, if people know, I like to go back as far as they can. So at least if you're the person sitting in my clinic, I'm going to ask you about your kids. I'm going to ask you about your siblings, your parents, your aunts and uncles, your grandparents, and their siblings. And if possible, we can get to great-grandparents. I do believe, I do get concerned in families that have any family member that has diffuse type gastric cancer. on the same side of the family that we know the CDH1 gene mutation came from. It doesn't matter how far back they go. Those are people that I am going to encourage to talk to surgery, but if they defer getting a prophylactic total gastrectomy, we are going to do annual endoscopic surveillance. If we find any foci of signet ring cell and they still defer, then we're going to do every 6 months surveillance.
So going back to the first question about what about the variant case with one documented case of advanced disease, and it's still being classified as a variant of unknown significance in ClinVar? So that obviously raises some questions there.
Yeah, so variants of uncertain significance mean that at this point in time, all of the genetic testing companies, the data that's out there, no one can agree, and they have very specific classifications of how they classify a variant or a change in the gene as benign, likely benign, pathogenic, likely pathogenic. So if there's any disagreement or all of the genetic testing companies are still defining it as a variant of uncertain significance, if the management recommendations are to go based on your personal history and your family history. And so if I have a patient who has a family history of a confirmed diffuse type gastric cancer, no matter how far back, and a CDH1, a variant of uncertain significance, that's a gene that I was going to be concerned about to begin with. And then we find a variant of uncertain significance in that gene, I am going to treat them as if they have hereditary diffuse gastric cancer. But the newest study that came out from NIH actually says that in those instances, we can potentially do the annual surveillance, the upper endoscopy with biopsies, for a number of years in a row. And if over time we don't find anything, we potentially can increase that interval out to maybe every 2 years. So I might not be as pushy about getting your stomach out.
All right, so 2 more questions. Risk is also dependent on the number of confirmed hereditary diffuse gastric cancer cases in a family known to have a pathogenic mutation. What can you say about the risk as it relates to family penetrance?
That's a good question. So I really, at this point, I get concerned about any family that has even one confirmed diffuse gastric cancer case. The families that I am trying not to push towards prophylactic total gastrectomy are the ones with only the lobular breast cancer in the family and absolutely no cases of diffuse gastric cancer.
Okay. Lastly, what about the cases of stage 1 that never developed to a later stage after having multiple years of endoscopic surveillance?
Yeah, so that's a really interesting point. And this is an area like a hot topic of research right now in the GI community, because we do know that not every foci of signet ring cell cancer is going to progress to a late stage gastric cancer, but we have no idea how to predict which foci is going to progress and which one isn't. So, I mean, this has to be a discussion, shared decision making between you and your provider who's doing the endoscopies, and then maybe also just having a referral to surgery to talk about what surgery would look like. I do have some patients that are really adamant about not going on to surgery right now. And so for them, we've developed plans where we will continue to do endoscopic surveillance every year. And if I find a foci of signet ring cells, then I go on every 6 months for a while, and then we can go back to a year. So it is a little bit it varies, and it has to be a situation of shared decision making where both of you understand the risks and benefits of either progressing with just endoscopic surveillance versus going on to have the prophylactic total gastrectomy.
So Jim, so what if a patient has a first-degree relative, a parent that gets diagnosed with stomach cancer? How do they pursue seeing you for consultation in the program that you've developed?
So that's a good question. So our clinic is actually at the Digestive Health Center, the UW Health Digestive Health Center. I'm a gastroenterologist. I just have like special expertise in these types of syndromes. So I see myself and Dr. Kevin Patel. We see people in the Digestive Health Center. So you just need a referral or even to call the UW Health Digestive Health Center and ask to be seen in the genetics clinic. We also have genetic counselors that work with us in this clinic. So we try to do kind of everything in a one-stop shop where you come into the clinic, we review your family history, we help you determine if we think you are at risk for any hereditary syndrome. We offer genetic testing that day. Coverage does depend on the insurance provider that you have, and we talk about all that kind of stuff in the clinic visit. We can also mail saliva kits to you at home if you don't want to make that decision at that time about getting blood drawn. And There are options for out-of-pocket testing as well that we discuss with people. So it's a long appointment, but we talk about everything at that appointment.
I'm not sure if this is a redundant question, but what if it's a first-degree relative with a poorly diffuse adenocarcinoma in the body of the stomach, and then the siblings have the same CDH1 variant of unknown? Would you recommend it for them as well?
I would definitely recommend that person have at least annual surveillance of their stomach with that Cambridge protocol biopsies.
What are your recommendations for someone who has CDH1, the hereditary diffuse gastric cancer, and also has lobular breast cancer in their family? What are your screening and removal recommendations for the breast?
So since I'm a gastroenterologist, I don't have expertise in breast cancer, but what I do is I refer everyone to our high-risk breast clinic. And in the high-risk breast center, they will go through all of the recommendations for high-risk breast cancer screening, depending on the gene that's in the family and the pathogenic mutation that person has, which could include starting screening at an earlier age. It could include adding like every 6-month clinical exams or every 6-month ultrasound, certain types of ultrasounds alternating with MRIs of the breast. Could include recommendations for prophylactic mastectomy, depending on the gene. So we do have a high-risk breast clinic at the UW hospital that will cover all of those recommendations.
Well, one more. Go for it.
Question. I guess I'm curious about how we classify these people. Let's say within a family, one person has the CDH1 mutation, dies of stomach cancer, and another family member dies of stomach cancer but does not have that mutation. How are they classified?
That's an excellent question, and it's not uncommon because we often see this a lot with Lynch syndrome and colorectal cancer, because colorectal cancer is a very common cancer, and somebody in the family could have what we call a sporadic or random colon cancer that has nothing to do with the Lynch syndrome colon cancers in the family. So we see that more often with colon cancer than we do with gastric cancer, just because gastric cancer is less common. But it is very possible to have a random cancer in the family that's not related. So you want to make sure that we have data to show that person with the confirmed diffuse type gastric cancer had the CDH1 gene mutation. We want to have genetic testing done on the other person who had the other type of stomach cancer to make sure they didn't have the CDH1 gene mutation. And then we want to think about their age. Were they diagnosed at an older age? Did they have a history of H. pylori? Did they have any other, were they smoker, diet, obesity, acid reflux? We want to go through, are there any other lifestyle or environmental factors that we think were potentially related to that person's stomach cancer? Because if they don't have the CDH1 gene mutation, we know they didn't inherit that risk that's in their family. But there's some other reason why they developed gastric cancer. And we might make sure, I shouldn't say we might, I would make sure that that person gets a multi-gene panel test that includes the Lynch syndrome genes, includes other genes related to gastric cancer in addition to the CDH1 gene.
Just for genetic tests, the DNA result is enough or RNA analysis also?
So DNA, for these syndromes, DNA analysis is enough. But there are a number of genetic testing companies right now that are doing kind of free RNA analysis to see, along with the multi-gene panel testing of the DNA analysis, to see if they can pick up additional mutations that are not being detected with just the DNA analysis. But if you have a confirmed mutation on DNA analysis, that's enough.
So if I have negative result for DNA analysis, but they say your blood wasn't enough for RNA analysis, do you think I should do RNA also, or is that enough?
Yeah, if your family history is very concerning and we haven't been able to identify something, I would say I would go for RNA analysis.
All right, thank you very much. As usual, Dr. Weiss is just our lecturer. And she puts us to the rest shame and intelligence. We'll try and somehow mimic her intelligence there. So the next speaker is Dr. Mark Benson. He is an associate professor of medicine at UW. He is the section head for interventional and advanced endoscopy at UW. Oh, okay. I'll go right here. Oh, I'll go here. All right, this will be simpler. All right, so our next speaker is Dr. Mark Benson, and he is an associate professor of medicine at UW in the section of gastroenterology. As I was saying, he is the head section chief of our advanced interventional endoscopy, and he's going to be talking about gastric cancer, risk factors, and screening.
Thank you, Pat. Again, my name is Mark Benson. I'm one of the interventional GI doctors here at UW, and I'll be talking about risk factors and screening for stomach cancers. So when you're talking about risk factors, there are like environmental risk factors and there are genetic risk factors. And looking at all these different factors, probably the two most important things will be H. pylori, which we'll talk about, and then having a familial predisposition, that is having a family member that's been diagnosed with stomach cancer. So H. pylori. So H. pylori is a bacteria that can live in your stomach. The stomach is a really hostile environment. So most viruses and most bacteria can't live there. But H. pylori can. It's developed some mechanisms that enable it to live in the stomach. And it's a really common infection. Half of the world has H. pylori living in their stomach. Most people have no symptoms from it whatsoever. In fact, 80% of people have no symptoms at all. Only about 20% of people do, and they have like stomach pain after they eat, or they have nausea and things like that. It is the most common chronic bacterial infection for human beings. They think that humans are the natural reservoir for this bacteria, but there are other organisms, or there are other animals that do have it in their stomach, so other primates can have it in their stomach. And interesting enough, domestic cats can have H. pylori in their stomach, and there's a theoretical risk that a human being could get it from a domestic cat. So we have several types of studies that show that H. pylori is a risk factor for stomach cancer. We have epidemiologic studies showing that in areas of the world where there are lots of stomach cancer, there are lots of H. pylori infections. We've got cross-sectional studies showing that people who are diagnosed with stomach cancer often have H. pylori as well. We've got prospective studies associating H. pylori infections with gastric cancer, and then we've got clinical trials showing that it decreased rates of stomach cancer when we treat H. pylori and we eradicate it. We talked about this earlier, but the World Health Organization considers H. pylori as a group 1 carcinogen. It leads to basically chronic irritation of the stomach. And over time, that leads to this gastric atrophy. It thins the lining of the stomach. And then you get something called intestinal metaplasia. That's changing it from the lining of the stomach from one type of mucosa to another. And your body doesn't do that genetically 100% of the time. So you get what's called dysplasia, or precancerous cells. And that, unfortunately, then can lead to carcinoma, or stomach cancer, shown in the bottom right here. Again, a majority of people who have H. pylori in their stomach have no symptoms whatsoever. The people who actually get stomach cancer, basically it probably has to do with the type of bacteria, how aggressive that bacteria is in their stomach, and their genetic response to it. And then lastly, where that person lives in the world. Most strains of H. pylori that cause stomach cancer, they have a gene encoded in their genome called the CAG-A gene. And that gene basically produces a toxin, produces a protein that is like toxic for our stomach lining. Salt is a risk factor for stomach cancer. There's strong evidence showing that. In fact, they think in the United States we see a gradual decrease over the last 50 years in the incidence of stomach cancer. And they think that's potentially due to the rise in refrigeration and decrease in the amount of salt we need to preserve meats that we're going to eat. Salt basically leads to damages, it stresses out the mucosa, and that leads to cellular proliferation to replace that damage. And then that, in turn, promotes the effects of the carcinogens that we eat. It has a synergistic response to an H. pylori infection. What that means is basically if you have H. pylori and you eat a high salt diet, your risk for stomach cancer is significantly higher. So if you're somebody that always uses table salt, you are always adding salt to the food that you eat, your risk for stomach cancer, you have an odds ratio that increases by about 1/3. So nitroso compounds. So these are compounds that are generated after eating foods that have nitrates in them, like cured meats. So things like hot dogs, things like brats, sausage, ham, bacon, those are all produce these nitroso compounds. In 2015, the World Health Organization considers processed meats as a group 1 carcinogen. And that's in the same group as like asbestos or smoking. Regular consumption of processed meats increases a patient's relative risk that they're going to get stomach cancer by about 24 to 55%. And it's a dose-response relationship. The more processed food that you eat, the more processed meats that you eat, the higher the person's risk. But it doesn't take much. You can have 50 grams a day. That's like 1 hot dog a day, or 1 ham sandwich a day. That leads to a 21% increase in the risk for that person getting a stomach cancer. So BMI. So that's body mass index. So if you have an elevated body mass index, you have an increased risk for getting stomach cancer. But a BMI greater than 25 increases your risk. So I'm 5'11", and I weigh 170 pounds. So if I weighed 180 pounds, my BMI would be 25.1, and my risk for getting stomach cancer would increase. So you don't need much weight. It doesn't need to be somebody who's massively overweight. But for every 5-point increase in body mass index, you see a 23% increase in the risk for that person getting stomach cancer. Smoking. So compared to non-smokers, smokers basically have double the risk of getting a stomach cancer. It's more common in men, and that risk decreases after about 10 years of stopping smoking. It increases both the stomach cancer incidence as well as the mortality associated with stomach cancer. So Epstein-Barr virus, also a risk factor. We have a talk about that later that's going to go in much more depth than this. So Epstein-Barr virus is a herpes virus. It's the virus that causes mono. You get it through intimate contact with somebody who has it. It's different than other herpes viruses. It doesn't like flare up. You usually get exposed to it, you get the infection, and then it stays asymptomatic. But it's associated with different cancers. It's associated with lymphomas. And they think about 5 to 10% of all stomach cancers worldwide are associated with this virus. It's predominantly in men. And it acts as an oncogenic virus in stomach cancer, similar to what it does for different types of lymphomas. The mechanism by which it causes stomach cancer are basically not fully understood. So then having a familial predisposition, that is having a family member, having a parent, having a brother who has stomach cancer, that can increase your risk for getting stomach cancer by up to 10-fold. And that accounts for probably 10% of cases of stomach cancer. Dr. Weiss just spoke about truly hereditary syndromes, and that makes a small minority. That's only 1 to 3% of all people who have stomach cancer. There's this hereditary diffuse gastric cancer, which we talked about. Those patients are often recommended to have their stomach removed. There's this gastric adenoma and proximal polyposis syndrome. That's a syndrome that was just identified about 10 years ago. These people get polyps of the top part of their stomach. We scope them and we biopsy those polyps, and when we see dysplasia, when we see abnormal cells in those little polyps, it's recommended that they get their stomach removed. And then lastly, there's this familial intestinal gastric cancer. The genetic etiology for why that causes stomach cancer isn't totally known. I want to talk about screening. So screening for stomach cancer is really challenging because there are areas in the world that have really high rates of stomach cancer, and there are other areas that have a really low rate, which is different than colon cancer, right? So colon cancer is a really common cancer. 1 in 20 people in the United States in their lifetime will get a colon cancer, 5% of all people in the United States. So screening colonoscopies has been shown to decrease a person's risk from being diagnosed with or dying from a colon cancer. And those studies haven't quite been shown for stomach cancer screening, but we're going to talk about the modalities and the effectiveness of those modalities. So there are 2 main types of screening. So we can do upper endoscopies, and Dr. Fowle and I do lots of these. And so this is a more invasive test. Basically, we sedate people, we go in there and we look in their stomach, and we take biopsies throughout the stomach. It's more invasive, it has risks associated with it, both with the procedure and with the sedation, and it costs more. It costs a lot to maintain the equipment and to train the personnel to operate the equipment. But it's very sensitive. It can screen for precancerous conditions, and it can screen for things like H. pylori and look for ulcers and look for small subtle polyps. And then we have contrast radiography. That's less invasive. It doesn't have the same risks as the endoscopy, but it's a little bit less sensitive. Unlike colonoscopy, there are no large randomized controlled trials showing a decrease in mortality associated with gastric cancer screening. And unfortunately, these studies are flawed with something called lead time bias. So if you have somebody that's in a screening program, they do seem to get diagnosed at an earlier point, but it doesn't affect their overall life expectancy. There are some studies that Dr. Locante talked about earlier. So there are studies, like this is a Korean study, it's a retrospective study, in 20,000 people who have stomach cancer. And what they found was that screened patients were significantly more likely to be diagnosed at an earlier stage. And just like a lot of cancers, if you diagnose it very early, it's easier to treat than if you're diagnosed in a very late stage, like stage 4. And there are universal population-based screening programs in certain areas of the world, like Japan or Korea or Venezuela. In the United States, we don't routinely screen for stomach cancers like we do screen for colon cancers. And we really only focus on people who are of known high risks, which Dr. Weiss was talking about earlier. One point about H. pylori, I was talking about how that's such a big risk factor. There are some limited data showing that screening asymptomatic people for H. pylori in areas of the world that have lots of stomach cancer, that may decrease the rates of people getting stomach cancer. Currently, there's no role for screening for H. pylori in areas that have low gastric cancer incidence, like in the United States. However, there may be a future role for screening some people who have no symptoms in low-risk areas. So again, we talked about the risk factors. Probably the biggest risk factor for stomach cancer is H. pylori, this bacteria that leads to chronic irritation and inflammation of the stomach. There are some dietary things that lead to it. We talked about the genetic syndromes, but they make a very small proportion of people who have stomach cancers. And then we talked about screening modalities. We can do upper endoscopies to screen, or we can do contrast studies. It's controversial if that actually decreases mortality for people who have stomach cancer. But it seems, if you look at the data, it seems that people that are screened probably get diagnosed at an earlier stage. There may be a role for screening asymptomatic people, however, for H. pylori. Questions? Yes. That's a really good question. So we don't routinely test for Epstein. So the question was, if we're doing an upper endoscopy for various reasons, do we routinely test for H. pylori, the bacteria, or Epstein-Barr virus, the virus that we talked about? We don't. We do routinely check for H. pylori. We don't routinely check for Epstein-Barr virus. It's difficult to test for that. It's actually a little bit difficult to identify H. pylori. What they do is we do biopsies throughout the stomach, and we say, can we evaluate for H. pylori? It's sometimes difficult actually for a pathologist to see just because it's a very subtle little bacteria. But when they do see it, we do treat it. Again, you treat it, and you want to make sure that it's eradicated because we know it's a carcinogen. Good. Yeah, that's a great question. The studies really haven't shown that it's a really high rate of the person getting reinfected, but they probably do. Knowing what I know about H. pylori, actually GI doctors and GI nurses are at a higher risk for getting H. pylori. So Dr. Fow did my upper endoscopy probably 5 years ago, and I asked him to check for H. pylori, which I'm negative. So, yeah, in the back.
Your presentation is very well understandable for general people. Is it possible to share it?
Yeah, sure. I'm happy to share this data. I'm sure we can figure that out. Yeah, no, I'm happy to share this data.
A couple questions about diet. Well, first of all, not everybody checks H. pylori to all patients. Actually, it's say if most of you are Wisconsinites, actually H. pylori is quite rare. And so we did a study a number of years ago for people who come in with dyspepsia, discomfort, and we biopsied them for H. pylori. Only 1 or 2% of people have H. pylori. So it's a very small risk factor. number of years ago, people were doing it like at the grocery store, they were doing blood tests for it. But so asymptomatic, no risk factors is not routinely recommended. But Mark, diet, if you are in your 40s and 50s, can you reduce your risk at that point by changing your diet? Or is it sort of made up?
It's mostly with weight loss. So if you're obese, so obesity is associated with this non-cardiac, basically with this cardiac gastric cancer. So what that means is the top part of the stomach. So obese people have a higher risk for getting acid reflux. They get a higher risk for bathing their lower esophagus in gastric acid, and that puts them at risk because it's chronically irritated for getting stomach cancer. So I would say that to mitigate your risk would be to have weight loss. That probably of all those things, you can probably eat a hot dog every now and then, but I would just try to not be overweight. All right, so it's my pleasure to introduce Dr. Patrick Pfau. He's a professor. He's a mentor of mine. He's an advanced endoscopist. He's the chief of clinical gastroenterology in our division, and he's going to be talking about endoscopic staging and therapies.
All right, thanks, Mark. 5'11", 164, so it's good to know my risk is less than yours. So that's okay. This is going to be sort of where we sort of change the flow. We're talking about sort of after you've been diagnosed with cancer and some of the early treatments. So I'm going to talk about stomach cancer, the staging that's involved after you've been diagnosed, and some endoscopic therapies for early stage cancer. So these are my goals of my talk. We're going to first talk about gastric cancer staging, a little about the radiology methods and the endoscopic methods. And it's important to know why we do this as physicians, as patients, because often, oops, thank you, slideshow.
From current slide, do you think?
Sure. There you go, thank you. All right, that's bigger. All right. It's important to know if you're a patient, when you get diagnosed, why we do these staging tests. Often when patients are diagnosed with stomach cancer or any cancer, they really I just want it out, I just want treatment. You need staging to determine the correct treatment, and we'll talk about as we go on. And there's radiologic methods and endoscopic methods, which I'll talk about. And I'm going to start talking about, there'll be a lot of therapy this afternoon or later this morning and this afternoon. But I'm going to talk about gastric endoscopy therapy, or endoscopic therapy for gastric cancer. And that's really in a small group of people in sort of really early stage cancer. So that's where patient selection is very key for these early stage cancers. And there's two general methods I'll talk about for removing early stage cancers with a scope, mucosal resection and endoscopic submucosal dissection. So if we're talking about staging, we have to know what staging means in the first place. So this is the T&M staging, which is tumor, nodes, and metastases. It's what we all as clinicians use, but it's how we sort of apply our treatment to patients. And I'm going to go sort of backwards here. So M staging or metastases is the first thing we find out. Do you have metastatic stomach cancer or not? Obviously, the treatment is vastly different. If you're metastatic, you really can't be cured. So that's really the first thing, is metastatic or not. Nodal therapy, the presence of nodes, and that's not, if your node is distant from the tumor, that is also metastatic disease. But if it's close to the tumor, we call those local regional nodes. And really, they give prognosis. The more nodes, the worse prognosis. But they also drive our treatment. If you have local regional nodes, you often will get neoadjuvant therapy, chemotherapy, plus minus radiation before you have, hopefully, curative surgery. So nodes are important for staging. And then T staging is tumor. How much does the tumor penetrate into and through the stomach? It goes by T1, T2, T3, T4. T4 is if it goes to adjacent organs and all the way through the stomach. T3, also when it goes through the stomach, but not in adjacent organs. T3 is by far the most common stage we see in stomach cancer. In fact, I'd say of all the referrals we get for staging, probably, and they're not metastatic already, probably 89% of people will have T3 staging, which is local regional, which also gets neoadjuvant therapy prior to surgery. T2 is where it just goes into the muscle layer, very hard stage to actually identify with any imaging modality. And then T1 is what we call mucosal or submucosal based. Those are important because those are the ones that we can remove and treat endoscopically. So that's the staging criteria we use. This is how we stage. We first start out with a CAT scan. That is the sort of primary first staging method we use once a person has been diagnosed already with stomach cancer through an endoscopy. And it's really a good test for metastatic disease. And that's again that first dividing point, is it metastatic or not? It's good for seeing metastases in the liver, lung, omentum, peritoneum, and for distant nodes. If you have metastatic disease, we often will do a biopsy to prove that by tissue. It's good, not great. It particularly misses disease in the peritoneum, which cannot be seen, and that's why we sometimes also do laparoscopic staging in these patients. CT staging is not that good for that T staging. T staging drives whether we can take the tumor out with an endoscopy and when you need neoadjuvant therapy. It just doesn't see the wall layers of the stomach good enough to make it the primary staging for T staging. Accuracy only about 50 to 70%. It also is okay, but not great for nodal staging. It's primary because CAT scan just uses the definition of a node that's a centimeter as positive or negative. The problem is there's a lot of inflammatory nodes that are greater than a centimeter. There's a lot of malignant nodes that are less than a centimeter. And these two are pretty simple CAT scans that sort of demonstrate that. This is a CAT scan that shows metastases throughout the liver. You're done with your staging then. That needs to be treated primarily with chemotherapy. Here's how and that's why CAT scan is such a good test originally for that. Here's sort of a picture of why, or a CAT scan why CT sometimes can have some weaknesses. Very thickened stomach, has gastric cancer. You can't tell the layer of how much the tumor involves into the stomach layers and through, so it really can't give you good T staging. Also, this person has a couple of nodes here. And again, you don't know if they're malignant or not. It could be inflammatory. So it's okay for T and N staging, but not great. And that's why we need other modalities to stage other than just CT. PET scan, just very briefly. PET scan is a imaging that can tell us a little more information than the CT scan sometimes. Tumor lights up hot, and this is the tumor right here. It's not routinely used in stomach cancer staging. We use it very common in esophageal cancer staging, but it can be benefit for equivocal findings in CAT scan. One of the problems with PET scan is not all stomach cancers light up with PET scan. So really in 20%, 1 in 5 patients, it really isn't a good test at all. It really can't, again, give that T stage or tumor staging. You can see right here, this is the tumor right here, okay, for diagnosis, but you really can't tell if it's invading through the stomach or not. It's good for nodes way outside. So if this is your tumor and the node lit up here, that would be a positive node. It's very good for that. However, if nodes, those local regional nodes, which again can drive neoadjuvant therapy, around here, it's very hard to tell apart the primary tumor from nodes. So it's good sort of as an extra test sometimes for metastatic disease in about 5 to 50% of patients or 60% of patients when that can find areas that CT did not. So it's a good complementary CT. We don't use it all the times. We use it sometimes. The other staging we use really primarily, and really there's 2 staging tests that everybody who has stomach cancer gets diagnosed, is CAT scan first, rule out metastases, and then this test called endoscopic ultrasound, because this is really actually the best test for that T, depth of tumor invasion in the stomach, and N, does it have local regional nodes. And so once you've done a CAT scan, there's no metastases, everybody should get an endoscopic ultrasound. One thing, actually, if you have metastatic disease, you don't need endoscopic ultrasound. It's not uncommon that people still send this patients who already have metastatic disease for this test. It really has no use if you're metastatic. And so the EUS findings for staging really drive whether, again, we can take this early tumor out with a scope, and whether the person needs neoadjuvant therapy with chemotherapy and radiation prior to surgery. So it's T and N stage actually are pretty good for T staging. For T1, 2, 3, 4, it has an accuracy of about 75 to 90%. It's really good, which is the most important thing, in telling is this T3 disease or above, because those are the people who, if they're not metastatic, get neoadjuvant therapy with chemotherapy and radiation followed by surgery. So that's very important, and it's very good for that. It's also quite good in telling apart that T1, very early disease, and those are the ones that can be treated with a scope and don't even need surgery. So what we need the EUS staging for is quite good at. It's also good at nodes as well, but 80 to 85% accuracy. Often with nodal disease, it's already a T3 disease, so they're both considered what we call regionally advanced. We sometimes will put a needle into a node to further improve our accuracy of staging. We don't do that in everybody because often the needle has to go through the primary tumor, but again, so one way we can further improve our staging with the endoscopic ultrasound. These are a couple of sort of classic pictures of what we use or what we image with endoscopic ultrasound staging for gastric cancer. For a patient, I'm sure that there's many patients here, you've already had plenty of endoscopies already. Really not much difference for a patient. The endoscopy, endoscopic ultrasound just lasts a little bit longer. The scope has a little ultrasound on it, so we put the ultrasound inside the patient, inside the stomach, and that allows us to stage. And you can see right here, that's our transducer in the stomach. This is the gastric cancer right here, and this is a classic T3 tumor. The muscularis propria right here, okay, that is intact right here, but here's the tumor, and really you don't see any muscle layer, and the tumor is breaking through the entire stomach wall, has these little pseudopods here. This is a T3 disease. This is a disease that we would send to oncology and surgery for neoadjuvant therapy, followed by surgery. And again, most people that come to us for staging with endoscopic ultrasound have this stage. This is a slightly different, and I'll be talking more about therapy for these T1 diseases. Very rare, stage 1, T1, by well less than 10% of all cancers we see in the United States. But here's the tumor right here, and here's the muscle layer right here that's all intact. It's not invading the muscle layer at all, which would be a T2, definitely not invading through. This is the type of tumor that we can resect with a scope. Even though it's called the submucosa, which is right above here, that's all intact. So by the staging, earliest stage disease, we can have a great prognosis, and we can take this out with a scope rather than need for surgery. Final endoscopic staging is more actually done by the surgeons than by us, is laparoscopy. And this is we talked a little bit, this is more going back to that M disease or metastatic disease. CAT scan is good. It's not great for peritoneal disease. So many surgeons, after you've got a CAT scan, no metastatic disease, you've had an endoscopic ultrasound saying you're locally advanced, meaning you can be cured with chemotherapy, radiation, plus surgery possibly. The surgeon will do a laparoscopy before they do the surgery, and they'll put a little scope inside your peritoneum belly, and we'll see these little spots, and they'll do biopsies, brushings, and washings to further increase the yield of staging. If you have peritoneal disease on laparoscopy, again, you cannot be cured, and you'll be treated with primary chemotherapy. As many as, not quite a third, but 1/5 to 30% of patients will have peritoneal disease not seen on CAT scan. It's sort of why we often do a laparoscopy before surgery, and I think one of the surgeons will be talking more about this coming up shortly. So that's the staging part. Again, it's very important because it's not just prognosis. Staging, the reason we do these staging tests is because it drives what type of therapy to give the patients the best outcome possible. I'm going to shift a little bit here to now to endoscopic treatment of gastric cancer. And this is a small subset of gastric cancer, especially in the United States. There's going to be early gastric cancer, stage 1, stage T1, T2, just involves the superficial areas of the stomach. So really, in these patients, patient selection is most important. We don't want to do endoscopic therapy on people who have advanced disease because it won't do any good for the patient. So you first of all want to make sure on the CAT scan ultrasound there's no metastatic disease, there's no nodal disease, it doesn't go through the whole stomach. We cannot cure those with endoscopy. We shouldn't even attempt to, obviously. Other selections where the outcome is better for endoscopy, these we can't take out very large tumors with endoscopy. In fact, usually larger tumors are more advanced stage. So generally, we take out tumors at 2 centimeters or less. If it's elevated, if it's a flat lesion, harder to take out, it gets down to about 1 centimeter. The histology is often after we take it out, and the histology predicts the chance of recurrence. Once we remove the tumor with the endoscope, if they have, we call well or moderately differentiated tumor, good outcome, less chance for recurrence. Obviously, if it's just in the superficial layers, very much less chance for recurrence. And same thing with having no lymphatic or venous involvement on the histology. And also, we do much better with non-ulcerated, with ulcerated tumors, and that's primarily because if a tumor is ulcerated, it's probably a more advanced stage, and it's also harder for us to get out. So if you have smaller, so this is a small group of people, but it's smaller tumors, good favorable pathology, non-ulcerated tumors, we will cure the vast majority of people with the endoscope, and really the recurrence rate is really less than 5% with this, if they meet this criteria. I talked earlier, there's 2 ways we take out early tumors. One is something called endoscopic mucosal resection. One is something called endoscopic submucosal dissection, done somewhat differently. ESD is a little bit newer of a modality used in the United States, but definitely used in Asia more. And that's expanding the criteria of tumors. We can take out larger tumors, ulcerated tumors, etc. And I'll talk about that briefly here. So this is sort of how these therapies work. All right. For a patient, again, I know there's no patients here. For early stage cancers, why this is important, these therapies is this is an outpatient procedure. You come in, endoscopic mucosal resection takes at most 45 minutes. You wake up with no pain, and the cure rates we'll talk about are quite high. So it's much less morbid than a surgery, even for a stage 1 cancer that gets treated with surgery. For endoscopic mucosal resection, more data because it's been used longer than ESD. This is how it works. Again, these are all done with small tumors, usually less than 2 centimeters. There's the CAP method and the band resection. So here's your little tumor here. For the CAP method, you go down, we go down, put a little cap on our scope, and we have working devices that can go through our scope. We first inject a type of fluid underneath to lift up that cancer. We use anything from saline to sometimes put some epinephrine in there so it doesn't bleed. We put some dye in there to mark where our margins are. Now we very commonly put some gels, lift it up higher. We inject first, that lifts it up. That does 2 things, easier for us to take off, and it separates the submucosa from the muscle layer because we do not want to get in the muscle layer because it will cause perforation or won't get the whole tumor out if it's in the muscle layer. So this separates it, makes it safer and easier for us. Once it's lifted up, we put a little snare around here, and just like a snare, a polyp in the colon, resect it, standard snare electrocautery, and then actually take it out. Sometimes if there's any bleeding, we'll treat bleeding right there. If it's a big defect, we'll often put a little clips there to close it shut. And this is actually a patient just from a couple weeks ago. This is with the second technique, the band resection, probably even more commonly than the cap resection because it's so easy to do. So this is a very subtle little tumor here, right here. Okay, probably right about 1.5 to 2 centimeters. This got sent to us from an outside doctor who saw this in biopsy, a little nodular bump they called it, came back as adenocarcinoma. So we go down with a band. This is a special device, and we find this. We suck this tumor up. It gets sucked into this scope here, and we put a little band around it. And you can see here, see this nodular tumor here? Now it's in this area here, and then through this device, through this little band area, we put a snare, and then we cut either just below or above the band, and it takes out the tumor. And then you can see right afterwards here, when this is muscle right here, it's right down to the muscle layer, and here's where our cautery margins are. This person actually went down again. They still had a little tumor right here. We put a second band on and resected it. Then our pathologist gives us a call in a week or so and says, are your lateral margins negative or positive? And even more important, are your deep margins negative or positive? And this person, they called back and both margins were negative. Very important if you are a patient who's having early cancer treated in endoscopic therapy, you are going to see a lot of us over the course of the year after we do this. It's primarily a surgeon will take surgical margins above and below the tumor. We don't have that option. The only option we know that you're cured is frequent endoscopy. So after we take this out, I'm going to bring you back in 3 months, take a peek. For instance, I think there's a patient with Dr. Zafar I did about 6 to 9 months ago, got it all out. I went back and I've been biopsying every 3 months. Then I do a little cautery to buzz off either radiofrequency ablation or cautery to treat the edges in the future too. First year, I probably do the people every 3 months and keep a very close eye on it to make sure it's a definite cure. And outcomes with EMR, quite good actually for the correctly selected patients. If it's less than 2 centimeters, we get about 90% of the lesions out. Bigger than that, we start to get so-so and are not quite as good. In-block resection is quite good. That means you got it all out in sort of one bite. More in-block resection, less chance of coming back. So if you get, with EMRs, we're at about 70-80% of getting in-block resections. This case I just showed you, it was not in-block resection. So I took one piece out. I had to go back and take another piece out. But with in-block resections, better chance for complete cure, less chance of recurrence. And there is a recurrence in the EMR of about 2 to 35%. He still has tumor there. However, we still cure this. We go back in and resect it later at a future date. The most important part of this actually is not our ability to resect it and get it completely, is we can do that, and survival of EMR for early cancers is just as good as surgery, greater than 95% 5-year survival, which Dr. Lakhani said that we consider that cure. There are complications, bleeding and perforation, but only about 3%, and usually we can treat that with a scope by clipping it at the time of the endoscopy. The second method we use is something called endoscopic submucosal dissection. This is a relatively newer technique, still used in the United States fairly commonly, used very commonly in Asia. It's a little bit more involved, takes more training, definitely takes longer than 45 minutes, but still done as an outpatient. Go home that day. Here's the tumor right here. How we do this, we mark it usually with a little cautery in circles that we know what to take out. Then we also put in that same lifting stuff, lifting agents to lift it up, make it easier for us to take out, separate the muscle layer from the submucosa. Then we sort of cut around the edges, and then use special cutting knives and resect all the way through. And you can see at the end, this tumor is gone completely. It's all down the muscle layer, and then we close it with clips. And works quite well as well. However, this usually needs specific training, whereas the EMR might take 30 to 45 minutes. This could take 1 to 2 hours. However, it has expanded our ability to get out larger lesions, more complicated lesions. And just like the EMR data, the ESD data is quite good. It really, again, it improves our ability to take larger, more difficult lesions out. It improves our in-block resection, meaning we get it all out the first time. That means recurrence rates are much less with ESD than EMR. Again, though, 5-year survival rates are, again, fantastic. This is early disease, but the 5-year survival is 93 to 100%. 5-year recurrence-free dates even higher, 98 to 100%, is equal to that of surgery for early cancers. Complications are a little bit higher with this ESD as opposed to EMR. That's primarily because we're taking out bigger, larger, more complicated lesions. A delayed bleeding, meaning after you're done, upcoming days, is about 5%. Perforation rate is about 5%, which is higher than EMR. Usually, though, we can actually treat these and close these with endoscopy without need for any surgery. But if we need the surgeons, we'll still call them in. But this is usually done with mild risk for complications. So conclusions about the two things. Again, this is the sort of the shift talk from once prevention to once you've made the diagnosis. Staging is crucial, and it's why we do these staging tests in patients who've been diagnosed with stomach cancer, is to give you the best treatment possible, the least invasive, and the best chance for cure and best chance of outcome. And we use CT scan and EUS in almost all patients, and laparoscopy in some patients. And then endoscopic treatment is really based on the smaller, earliest type cancers, stage 1, stage T1. Those are rare cancers in the United States, 5 to 10%, much more common in Asia. But if we do choose the patients correctly, both the EMR and ESD bring cure rates as high as 95%. The question about this endoscopic treatment is, can we match the data that's being given to us from Asia, Japan, South Korea? Much more common to get gastric cancer in Asia, much more common to get early gastric cancer. So the endoscopists are much better, and they're providing the data. I think we will get the equivalent data here at US, but there's not enough data yet to say we're as good as they are in Japan or Asia. But again, now at present for early stage cancer, T1, really endoscopic therapy is the first modality you should have. Doesn't mean you can't have surgery afterwards. And there's studies on people who had endoscopic therapy, failed, still went to surgery, and still had cure rates over 95%. All right, I wrote this entire talk on the beach last week, and so if I had any major mistakes, I was really trying to keep the sand out of my computer. So any questions, I'd be happy to take those.
In the back.
Do we know how long does it take for a tumor to go from one stage to another, T1 to T2?
Oh, that's a good question. That's what all cancers are going to. It takes a long time, and that'd be months, plural. Right, and so again, this comes from a patient perspective. I think people really get freaked out because we, as the endoscopist, myself, Jen, and Mark, will diagnose a stomach cancer, and people get really freaked out if they can't get their CAT scan until next week, and the US until 2 weeks. Nothing's going to change in that period. So this is from a stage T1 to T2, meaning your therapy is going to change. It would take months of waiting for that to happen. So yeah, it's months plural. We don't know the exact time frame, but it's a long time.
Pat, you talked about when we resect these small cancers, why is it so important that we raise it up off the muscular layer or the MP layer before we remove it?
Well, for two things, cure and safety. So again, we cannot cure endoscopists with endoscopic therapy, cannot cure patients if the tumor goes into the muscle layer. Also, if we are taking off the muscle layer, by definition, we're going to perforate the patient. So injecting and lifting separates the submucosa or mucosa, so the skin of the stomach, from the muscle layer, and allows it to be done easier and more safely for the patient. All right, I think it's break time. It was good.
Thank you.
What's that? Sure.
definitely do that. What's
Okay, if we could ask everyone to take their seats, we'll get started on session 3 here shortly. I'm going to find a way to use food stuff to come today. Yeah, right. No, she doesn't yell. I'm the yeller, and so she doesn't like it, but it is. Okay, so I'm Dan Abbott. Again, I'm one of the surgical oncologists at UW. This is Patrick Varley, one of my partners, also a surgical oncologist. We'll be moderating this session, and we will start with the esteemed Patrick Varley talking to us about comprehensive staging and surgical treatment of gastric cancer.
All right. Thank you, everyone. It's my pleasure to be here and giving this talk. So thanks for No Stomach for Cancer for the invitation and for everyone for organizing. So I'll be speaking briefly about some of the surgical considerations for staging and management of gastric cancer. Be piggybacking off of the talks you've heard before, especially Dr. Pfau's last presentation. So I think, some people are interested in the history of surgery, myself included. And so just a little bit of background kind of about where we came from that would provide some insight onto some of the, how sort of impressive it is that we've gotten to where we are today. So in 1879, this was the first distal gastrectomy performed in Paris by Jules-Émile Péan. And so unfortunately, though he did a distal gastrectomy, that patient died on postoperative day 5 from unknown reasons. This was actually just around the time that Lister developed antisepsis, so just the beginnings of understanding how to stop infection around the time of surgery. Anesthesia was still being done with ether, sort of an ether mask at the time. 1881 was the first successful distal gastrectomy by Dr. Billroth in Vienna, so sort of the father of modern gastric surgery. This picture here on the right is a picture of Billroth performing his third gastrectomy, actually. That was in Vienna. In the beginnings of this, the surgical mortality was 70%, so 70% of patients would die in the postoperative period. 1887 was the first total gastrectomy, and then we sort of went on. People got a little bit better over time, but in the 1940s, we realized the importance of lymphadenectomy and sort of the importance of the lymphatic system, which was borrowed from other parts of cancer research. The first stapler was developed in Japan in 1962, then sort of refined in Russia, and then there's actually a very interesting story about how that was kind of smuggled into the United States in the 60s and refined even further by the U.S. Surgical Corporation. Then the first endoscopic resection in 1988. 1994 was the first laparoscopic gastrectomy, and then in 2002, the first robotic gastrectomy. So as you see, a lot of the pioneering work for gastric cancer has been done first in Germany and then a lot in Japan and Asia, as you may have heard, because of the incidence of gastric cancer in that population. So the general staging of gastric cancer, I won't belabor this just because I think Dr. Pfau went over some of it, but there's, sort of break this down into 3 groups, right? There's local staging, that's the stage of the tumor or T stage. The mechanism for evaluating that is EUS, and that is the best way we have now of determining the T stage preoperatively of a tumor. There's the regional stage or the end stage. So this is looking at the potential lymphatic spread to the lymph nodes. This can be done by EUS. Also, most often we will pick this up on a CT scan, which is a routine part of staging. And then in some patients, PET scan or positron emission tomography can provide information on the staging, both distant and nodal disease. And then the distant stage is the M stage. So we pick up distant metastasis by CT scan, PET scan, and then staging laparoscopy. I think one important thing to sort of go over here is that there's two types of staging for gastric cancer. There's the clinical stage, so that's what stage a patient is based on all the information that we get sort of during the initial workup. Then there's the pathologic stage, which we can't tell people really until they've had a formal gastrectomy, and the pathologist can look at the primary tumor as well as look at the lymph nodes and anything else. I will also say that, you know, everyone always will ask us when they come in sort of, what stage am I? And yes, it's sort of broken down into stage 1, 2, 3, and 4, and different combinations of these sort of put people into those buckets. In general, patients who have distant disease, so metastasis to other organs, that's stage 4 disease. Patients who have lymph node metastasis would be stage 3 disease. And then stage 1 and 2 disease are those sort of different T stages, but no lymph node disease. The real important thing when people come in and first meet us, really we're not trying to put people in these buckets of stage 1, 2, 3, and 4, which have prognostic significance. But as we try to develop a treatment plan for people, it's really important to know, it's sort of binary. Has this gone outside of the stomach and lymph nodes and is stage 4 disease, or is it less than that? If it's less than that, those are the patients where we oftentimes have the most option for local strategies, whether that's surgery or other things. So just an example of CT scans, if many of you have seen some of these. So a CT scan, right, is done where there's a variety of different views, but it's done, can be done quickly. And then it presents these images which sort of slice people like a loaf of bread, where this is the front, this is the back, the left and the right. And you can kind of see through the stomach here with contrast, which appears white. And the thing about gastric cancer is it can be sometimes subtle and difficult to pick up on CT scans. So sometimes it's just this thickening in the wall of the stomach here that we see. Obviously, if there are lymph nodes in the area, we can pick that up. And then in some people who have bigger tumors, obviously it becomes a little more readily apparent where we can pick that up. The other important thing is then you see organs here like the liver. If we see anything in the liver, that can be suggestive of patients who have metastatic disease. So a PET scan, many of you have probably heard about this. A PET scan operates it's very similar in a way to a CT scan, but instead of an IV contrast, people get an IV radio tracer that is bound to a sugar molecule. And the principle is that tumor cells are very active, right? They're dividing very quickly. And so they take up that sugar more than other tissues, and it allows us to see the tumor, whether it's in the stomach or other places, by sort of combining a CT scan with that nuclear medicine scan, the PET scan. Generally, it's recommended for patients with tumors that are staged initially greater than T1. The reason for that is that if you have a T1 or below tumor, the risk of distant metastasis is low, so the value of a PET scan may not be warranted. I would tell you, I think there's, you talk to different people about the value of a PET scan, and I think in a lot of ways it's an adjunct to all of the other staging methodologies we do. I think it's very helpful when we have findings on a CT scan that are equivocal, meaning we see something and we can't quite tell what it is, whether it's a normal variant or something that a little big that shouldn't, that's relatively normal. A PET scan can kind of unmask some of those findings. And the reason why I would tell you it's an adjunct is these numbers here. So when we look at diagnostic tests, we talk about the sensitivity and specificity. So sensitivity is how much it picks up. Like if there's something there, the test will pick it up. Specificity is if it shows as positive, that is a real positive test, is kind of the way to think about it. So a PET scan, it only will pick up about half of lymph nodes that end up being positive. So the sensitivity is okay. But if a lymph node lights up on the PET scan, then it's likely to be real. And the same numbers go for metastatic disease. So it's not the greatest screening test because it doesn't pick up everything, but it is really good at sort of confirming things that are real. Staging laparoscopy, so is sort of still a mainstay of treatment in patients with gastric cancer. It's usually used in patients with T2 or greater disease on initial endoscopic staging. This is a standalone surgical procedure, so patients come in the morning and we use 2 or 3 small incisions to take a look inside of their belly. And really the goal is to determine whether or not they've had spread of disease outside of the stomach, oftentimes to the lining of the belly or to other places, especially on the liver or within the fatty apron that sits over the intestine called the omentum. So the issue with this is that both PET scan and CT scan are not very good at picking up very small things. And gastric cancer is known to sort of have these types of metastasis. So the laparoscopy is something that allows us to see these small things even if they're not picked up on CT scan. We not only look for these grossly visible lesions, but we also instill saline and sort of wash the abdomen and send that for cytology to find any floating cancer cells. The reason we do this is even in patients who have no evidence of metastatic disease on a CT scan or PET scan or anything else, somewhere between 10 to 30% of those patients may have metastatic disease that we find on laparoscopy. These rates are really sort of determined by how advanced the original tumor is. In patients with T3 or T4 lesions, it might be closer to 30%, whereas in patients with T2 lesions, that is closer to 10%. So staging laparoscopy remains sort of an important part to stratify patients when they first present. So I tell you, once we get through with these initial staging tests, the general treatment strategies, and I think Dr. Boha will talk a little more about sort of the chemotherapy aspect, but I'll just give you a general outline. For early stage disease, that's T1, N0 patients, so small primary tumor, no lymph nodes that we can see. Resection, whether that's endoscopic like Dr. Fout talked about versus surgical resection can be an option. For local regional disease, that's larger primary tumors and positive lymph nodes. We would generally talk about chemotherapy and surgery, and in the current era, that would oftentimes be chemotherapy first. That's neoadjuvant chemotherapy followed by surgery. And then in patients with distant disease, the treatment options really are chemotherapy. The roles for surgery really are for palliation, meaning patients who are having complications from their tumor, bleeding or obstruction. There can be roles as sort of, I would tell you, one of the areas that we're investigating in the context of registries and clinical trials. Are there select patients with distant disease that we can treat surgically that have good outcomes? And I think that data is still evolving. And as our systemic therapies get better and we get better about predicting who may do well and who may respond to different types of therapies, the role for surgery in those patients may expand, which is actually the same thing we've seen in other types of cancers, such as colon cancer or breast cancer or anything else, where as our whole body treatments get better, then the role for surgery to treat metastatic disease may improve. So there's two parts, if we talk about surgical management specifically, there's two parts to the operation. Really, it's resecting a piece of the stomach with a tumor and then the lymph node dissection. So when we talk about the resection, the actual resection for dealing with the tumor in the stomach itself, how much of the stomach we take out and what parts of the stomach we take out is really dictated by where the cancer is and in the nature of the cancer itself. So for cancers in the distal part of the stomach, we can offer a distal gastrectomy. For cancers that are closer to the esophagus in the proximal part of the stomach, the options are, traditionally had been total gastrectomy, but there's evolving use of proximal gastrectomy, and I think Dr. Kelly will be talking a little bit about the benefits of that later. For patients with diffuse gastric cancer, meaning gastric cancer that extends, further in the stomach, or those with hereditary syndromes whose stomach is at risk for developing other cancers if we were to leave some in, the options there are total gastrectomy. And then in patients who have locally advanced cancers, meaning cancers that start in, say, the distal part of the stomach here and then grow into the colon or the pancreas or spleen, then we would take out all of the affected organs together, assuming that's feasible. I tell you the general tenets of surgical resection are we try to get 5 centimeter margin, so 5 centimeters from the tumor. Obviously, if you have a tumor here or here, the margin closest to either the duodenum or the esophagus, we generally cannot get 5 centimeters, but then we would get 5 centimeters on the other side. And really the goal is to get an R0, you will hear it called, or a margin negative resection. So no cancer cells at the margin that we can see. So once you take out a piece of the stomach, you have to obviously put things back together so people can eat. And so how do we do that? Well, there's 3 general types of reconstructions, and they would be the Billroth 1. So that would be you take out a piece of the stomach here, and then you sew the stomach directly to the first piece of the intestine, the duodenum. The benefit here is that it's physiologic, so you put everything back together essentially the way that it was. You still have access to the duodenum if you would need to do a scope. The issue is that, some people would say it's actually technically not very challenging because it's just putting things together. But the details on how you can mobilize the duodenum to reach that area and the instances where this works can be a little more limited, and it's a sort of a surgeon comfort thing. People who are trained to do this operation are better at doing it, and I will tell you that this is popular in Asia and not necessarily as popular here in the United States. So Billroth 2, that is a very common operation where, same principle, you take out this distal part of the stomach, you close off this piece of the duodenum, and then you bring a loop of intestine up and do what's called a side-to-side anastomosis. So the pancreas and bile from the liver over here go through here and meet the food which enters into the intestine here and goes down through the rest of the intestine. The benefits, there's only one anastomosis. It's often faster to do. The one issue is that patients can suffer from bile reflux, and the more stomach that we take, the more that reflux can be. So usually if we have to take more than about 2/3 or 1/2 of the stomach, oftentimes we would worry about a patient's bile reflux, and that may not be a good option for them. Finally, the Roux-en-Y reconstruction, which can be done for both subtotal gastrectomies, meaning we leave a piece of the stomach, or a total gastrectomy where you take it all the way up to the esophagus. In this, you actually form what is a Y. So there's one piece of intestine that goes up to the stomach, and then you make another connection to this piece of intestine which goes over to the liver and the pancreas and drains the enzymes. So the benefit here is that patients don't have reflux. This limb can reach very easily. The downside is it can take a little bit longer and requires an extra anastomosis. It also leaves patients potentially open to internal hernias, so things can kind of twist around in here. And if patients for some reason would need to get access to this for endoscopy, you can't access that easily, though. I bet Dr. Fowle and Dr. Benson could tell you they can get there. Sometimes it's just a little bit of a challenge. So if we knew that we were going to have to do that at some point, not a good option. Lymphadenectomy, so that's getting all of the lymph nodes to evaluate whether cancer has spread. There's two general ways to think about this. There's a D1 lymphadenectomy, so that's a limited lymphadenectomy where we take all the lymph nodes close to the stomach. There's a D1 plus where we sort of take the ones close to the stomach and then a little bit on these blood vessels. These are the main blood vessels that go to the stomach and then here to the spleen and pancreas. And then there's the D2, sort of the most extended lymphadenectomy we routinely do, which takes all of these lymph nodes, all of them around the stomach, all of them around the main blood vessel that goes to the stomach. That's the celiac axis and the splenic artery. So there's been a lot that's discussed in the surgical literature about which lymphadenectomy to choose. I will just sort of summarize this and tell you that in the United States, historically, kind of people in Europe and the United States, people favored D1 or the more limited lymphadenectomy, whereas in Asia they favored D2 lymphadenectomy. There's been a number of randomized controlled trials looking at the benefits of one versus the other. The issue with the D2, because of it was extended, what people found was that the surgical risk, meaning the complications and death related to the procedure, were higher in the D2, in the extended lymphadenectomy group, though additional analysis has shown that that was because the surgeons would routinely take a piece of the pancreas and the spleen, and that was driving the mortality in that group. However, as we've sort of gotten better at this, and we don't have to take the pancreas and the spleen, that the risk of doing a D1 and a D2 are essentially the same, and that there may be some cancer benefit for doing the more extended lymphadenectomy. I will put a caveat here and say these trials were all done in an era when we did not have sort of modern chemotherapy. And I think there is, personally, I will tell you, I think there's a question about whether the extent of the surgery is, at this point driving things, or if, the chemotherapies we have now are treating that nodal disease that we were trying to get surgically 20 years ago, and can you do a more limited lymphadenectomy and use chemotherapy as an adjunct? I think that's an open question, but still the standard in high volume centers, especially for patients who present with nodal disease, would be a D2 lymphadenectomy. And again, this is just to show you, this line shows patients who died from gastric cancer who got a D2 resection versus a D1. So the survival of those patients, so fewer patients died of gastric cancer who got that D2 resection. And you can see early on, this again is a D2 group, so more patients died early because of complications related to surgery. So a big question that comes up is, how do we do the surgery, right? The traditional way was open with an incision down the middle. Then in the the 90s, laparoscopic surgery came on. In the 2000s, robotic surgery, laparoscopic and robotic both being minimally invasive. There's actually been 2 randomized control trials, at least showing, looking at laparoscopy versus open. And really what I would tell you, the way to summarize that is that the 5-year overall survival, or the cancer-related survival for both, is equivalent. There may be some benefits to laparoscopy. Those are shorter hospital stay, less blood loss, but similar complication rates. The disadvantages of laparoscopy is that there's a longer operative time and the learning curve is higher. So it takes longer or more cases to get good at laparoscopy than it does an open operation. What about robotic versus laparoscopic? Well, I would tell you my sort of how I conceptualize this is a robotic is much closer to an open operation than a laparoscopic is. And that's because the instruments are wristed, and it's sort of, if you can do an open operation, doing a robotic operation is somewhat similar. And so there's papers out there that show you that you can get better lymph node yield in robotic versus laparoscopic. That may translate to better outcomes, though they're not proven. Perhaps a shorter learning curve, but a higher cost, right? Buying a surgical robot for a hospital costs more money. I will tell you, if I summarize all of this, I mean, again, this is my editorial. If you're talking about cancer-specific outcomes, it doesn't matter which type of operation you have, right? They all are, they all get you to the same place. There may be some short-term benefit to a minimally invasive approach, but that's going to even out over, the first couple months of surgery. I think that the key thing is the surgeon experience. So if the surgeon you go to does a lot of gastric cancer and they do the operation open, then that's the way that, is the best in that situation. If you go to a surgeon who does a lot of gastric surgery and they do it laparoscopically or robotically, then that's a good way, then that makes sense to do it that way. I think that the problem we get into is when people start doing things they don't do a lot of, that's when there can start being issues. So I think the choice is really up to you, what a patient would like and what the surgeon is most comfortable with. So key points for patients, this is the end. I think multidisciplinary team. Surgery is a very small part of gastric cancer treatment. It starts when they first meet the gastroenterologist and the medical oncologist, and they go through all these things. So multidisciplinary team is key. The surgeon is only as good as the rest of the people that treats the patient with them. Multidisciplinary team, multidisciplinary team. Like, this is the key point, I think. Going to a place that treats a lot of gastric cancer, especially an NCI designated center, is really I think the key point for people who are seeking out treatment for gastric cancer. And again, it's a host of things, right? And it's things you may not even see. It's nurses on the floor who are used to dealing with gastric cancer patients. It's having nutritionists. It's making sure we engage PCPs and other medical specialties for patients who have other medical problems so that we handle those appropriately. And really this is, the volume outcome relationship has been shown across essentially every sort of more invasive surgical procedure, and showing that if you go to a higher volume place, patients do better. And just, everyone asks this question, right? Outcomes after surgery for gastric cancer really depends on the final stage. But even in stage 3 patients, I do think we have good outcomes for people. And again, in the context of, appropriate multidisciplinary care. So with that, I'll take any questions.
All right. Thank you, Patrick. So next speaking, we have Nabil Zafar. He's Nabil. One of our partners that joined our group about 3 years ago, and as Patrick and Caitlin are, he is an expert in minimally invasive surgery, and he's going to talk to you about some of the recovery after surgery for gastric cancer.
Thank you, Dan, and pleasure to speak with all of you today. I'm just going to try to find my talk. I don't know, is there a folder? Oh, it's on the, sorry. So just tagging on to Patrick's presentation, I'm going to focus my talk on post-operative care after surgery. So you had surgery, what happens after that? It's going to be a high-level overview, and if you have questions for some details, we can talk about that some more. Some slides, pictures are borrowed. I will talk about normal or expected post-operative course. If complications happen, then some things change. No other disclosures there. We'll talk about recovery, both short-term and long-term. Some differences between the partial, subtotals, and total gastrectomy that Patrick mentioned, and also between minimally invasive and open approaches. So let's talk about the short-term recovery. So you had your surgery in the hospital. What happens in the next first days to weeks after surgery, or what can you expect for a loved one or family member as well? So some principles of recovery that we use these days come under the term ERAS, or what we call enhanced recovery protocols, and they're essentially a few things that we pay particular attention to. Less fluid by vein, so we don't want to flood the patients with fluid. We used to do that before. Earlier walking, we used to keep the patient in the bed for longer and be very careful, but we are more aggressive now to make the patients walk earlier. Diet earlier, we don't starve patients anymore for long periods of time. We want to start diet early, and then less narcotic pain medication. Those are the primary drivers, but there's a lot that goes into enhanced recovery. And it starts, in the pre-surgery setting with a lot of education and counseling for patients. Patients meet nurses and surgeons. You want to give some energy drinks. We talk about regional blocks like epidurals for pain controls. And then during surgery, the anesthesia team is very vigilant about how much fluids we're giving, how much opioids, narcotics are giving during surgery. We're careful about the incisions and retraction. And then in early period, mobilization, meaning walking, and then tubes and drains, you want to get them out soon. When do we start feeding and eating? Eating is a consideration. We want to do that sooner, all within certain safety limits. And then with this, we've seen better outcomes, better patient satisfaction, get home sooner, recover faster, costs are less. So it's overall, for value of care-wise, it's very effective. So if you just go through the first few days, in the first hospital stay is about average 3 to 5 days. We're really allowing the body to recover. So any kind of surgery is trauma to the body. The body exhibits as a trauma, as if you had a crash, you fell down, and the body exhibits a reaction to that with different hormones and stuff coming out. We have altered the anatomy. We've done many connections, different things, like Patrick showed pictures of those. So we are watching for the complications, and a lot of that is monitoring that's going on passively in the background. Patients aren't aware of all of what's going on. And then pain control, we do different types of pain medications. And then we're doing some things, we're giving medicines like blood thinners and other things to prevent complications, and the walking, deep breathing is part of that. And the goal is really to transition off of any kind of hospital needs, so you're ready to go home and be fairly independent at home. And then preparation for discharge and getting the information you need on what to do after you get home. So the day of surgery, surgery happens, different amount of time period depending on what kind of surgery you're having, 3, 4, 5 hours. You get up, you're in the recovery area, you're drowsy, then you go to the floor eventually by afternoon, evening. Usually patients have a urinary catheter in place, NG tube, that's a tube going in the nose to the stomach or the part of the reconstruction area. And then maybe there's a drain in the belly. Sometimes the NG is not there, and you'll always be hooked to some IV lines and drips and things. Day one, next day, there's a lot of monitoring happening, heart rate, blood pressure, blood work, to look for, like I said, complications and making sure everything is going okay. But we want really patients to get out of bed and really sit at the bedside, stand, and progress to walking. Incentive spirometer is deep breathing, because when you have cuts in the belly, if you take a deep breath, it hurts the belly. So you want to incentivize that, and this kind of a machine everyone gets, or a toy. It just encourages deep breathing. The catheter gets removed. Slowly we take out lines and drains and give some blood thinners. A leak test, and I'll talk about that. Sometimes we do that, sometimes we don't on day one. Like Patrick mentioned, there's a lot of teams involved, even before surgery and throughout cancer care, even after surgery as well. The surgical team is surgeons, residents, students. They come and they monitor you. There's APPs, nurse practitioners as well that really help a lot in taking care of the patient. And then there's other teams, other members from a lot of teams. So you do see a lot of people coming in and out of the room doing their own specialized thing. Day 2 is more monitoring, more walking, more breathing. We start some home medications, transitioning less IV fluids, less narcotics, more education, wound checks, things like that. Day 3 often is a period of time where we do a leak test, and then we can advance diet. And usually we start with liquids, and you go home with liquids after that. A nutritionist typically sees the patient before discharge, and we talk about medications, gradually stop the IV fluids, and prepare for discharge. Just quickly about the leak test, and Patrick already told you that 2 different types. We make these connections or reconstructions here, and what we're really looking at for is that these connections are holding before you go home. Now, nothing is 100%, but we do a study that's an X-ray. You drink some contrast, and if it leaks out, we can detect it. The reason I'm just showing this is this. People might have heard about leak tests, but we do a lot of other kind of monitoring and testing in the hospital before going home. But the goals for discharge should be walking within reason, some pain control with medications by mouth, off of IV medicines, having bowel function, passing gas or bowel movements. It should be drinking enough liquids to avoid dehydration. And everything else should be looking okay, and then the patient and family should be comfortable with what needs to be done in education and stuff. Sometimes we give blood thinners on discharge for a period of time, so to prevent blood clots after hospital discharge. That might be a shot, usually, sometimes a pill. This is just a busy chart, and just to show that all of what goes on into an enhanced recovery protocol. There's pre-surgery, we're thinking about a lot of things, and fluids and temperature, drains, and then afterwards as well. Between a total and a subtotal meaning almost all of the stomach is gone, and here all of the stomach is gone. So in a total, we do almost the same things, but just a little bit slower. We're more careful. We look at patients more carefully, especially with their diet progression and through testing and things. Open surgery versus minimally invasive surgery, like Patrick said, there is some less pain or faster return to walking and bowel function in some studies, but so this is the incision of an open operation. This is robot, or you can have laparoscopic, but it does, like, everyone's pain tolerance is different, and recovery and hospital stay does depend a lot on patients as well. Post-op visit, and after you go home, usually within 1 to 2 weeks, we see you again in clinic, the patient. The family. And in the clinic visit, we're looking at the wound, we're looking at making sure everything's on track. We talk about diet and how that's going, might progress the diet. And then we really talk about the pathology report then, and see was the cancer, was it all taken out, were the lymph nodes, what other surprising things or not on pathology, was everything expected? And then according to that, we plan the next step, what's going to happen afterwards. I'll give a quick note on prehabilitation. The concept being the better shape you're in going into surgery, the better shape you'll be coming out of surgery. So maybe we can do things before the surgery event to optimize things. And then we use a trimodal approach, and a lot of that is some exercise, different kinds of respiratory, stretching, resistance, walking, and then there's some psychological support with education and things, and then nutritional support as well. Especially, some patients have outlet obstruction, they can't eat well, or losing weight, so we kind of try to optimize that. At UW, we do have a clinic called POSH, and it's a common thing in a lot of centers, at least those that do high volume surgeries. It's called preoperative optimization, and they do a lot of assessments before surgery, and then it's kind of personalized recommendations for the patient, especially for older patients who have a lot of other medical conditions on medications. This is just a list of things they screen for and try to minimize risks of delirium, complications, depression, nutrition. And so we work closely with different teams to help avoid some of this stuff in the post-operative period. I'll just quickly go over longer-term issues a little bit, and this is months to years. There's a lot of nutritional things that go on. As you can imagine, you take the stomach out, or most of the stomach out, there's going to be problems or differences in your lifestyle. I think the talk after lunch is by our nutritionist, and they'll probably go over a lot of these things about maldigestion and dumping syndrome and vitamins. So I won't touch upon that too much. But I'll talk to you a little bit about quality of life and surveillance, and that's what are some of the things that we're doing in the postoperative period. Now, most of these graphs are for patients who've had total gastrectomies, but some of them did have subtotals. But if you look at overall quality of life, there's always a dip, and then it kind of trends to come back, physical functioning as well, role functioning, appetite, fatigue. It's a bit of an older study. But even years after surgery, if you look at, these are different components. PF is physical functioning, there's cognitive functioning, there's social functioning, emotional functioning, everything dips, and then we slowly start regaining a lot of that. Most things, you can have differences in study methodology, but a lot of it does not always return back to baseline. Similarly, fatigue, nausea, vomiting, pain, sometimes increases, then it decreases over time. Some other things, especially financial difficulties, keep going down sometimes as well. Surveillance. So that's the other thing in the long term. Once you're done with surgery, clinic visit, months to years time, we do keep an eye on things for cancer. We worry sometimes cancers can come back, so we want to catch it earlier or as soon as we can to start treating it. And that involves clinic visits, which is a physical exam, and some imaging as well, and sometimes endoscopy. And the schedule of surveillance varies by your pathology or stage of disease and what else is going on, chemotherapy. But in general, it's usually every 6 months. Sometimes we'll do the first one at 3 months, but it'll be a CT scan, clinic visit, and usually a scope to look at the remnant stomach, if there is a remnant stomach, at a year. And we're really watching for early signs of cancer coming back so we can detect that. Now there's blood tests as well that may come into clinical practice. But we are really trying to optimize outcomes after surgery and continuously trying to be better. And this is just another thing that Patrick mentioned. The importance of being at a high volume center is we're always doing research on these things. We're always looking at what we're doing better, how can we do better. We want to decrease surgical complications, make the surgery itself safer and safer. We want to increase quality of life, patient satisfaction, decrease costs, and improve the cancer outcomes themselves. There's always newer techniques coming out between surgeries. There's newer medicines, newer protocols, and people familiar with these operations and how to manage them are always making the recovery period better and better. So in summary, enhanced recovery involves careful attention to the whole body. It's a big team effort between many team members, and particularly the patient and family are highly involved in this. The better shape you're in before surgery, the better shape you are usually after surgery as well. Long-term recovery can take time, but we're, the medical team, the surgical team, the teams are here to help your patients through this. Happy to take any questions if you have any.
Do you have any questions from the audience? Yes, sir.
After removing all stomach, where is the most vulnerable area?
Yeah, so like Patrick was talking a little bit about lymph nodes and other places where cancers can spread. So if we're talking about invasive stomach cancer in higher stages, the idea being that maybe some cells escaped the stomach and went to the bloodstream, to lymph node streams. So once the stomach is gone, when we do imaging and surveillance, we're looking at lymph nodes as well. We're looking at the chest. We're looking at the liver. So it can pop up at different areas. In other places in the belly, we call the peritoneum.
And I would just add, I didn't add this on mine, but I guess should have maybe put it as part of the decision for how much of the stomach to take. I think historically when we treating any kind of cancers, we always thought take as much as possible and then that'll reduce the risk that it comes back. I think our knowledge of gastric cancer and all other cancers has told us that that's not necessarily true. So we take as much as we think we need to get everything out. But if we can do that and save a piece of the stomach, the benefits that Dr. Zuffer talked about, right, of not having to do a total gastrectomy and the nutritional things and the quality of life can be worth leaving a piece of the stomach there without a risk of having a local recurrence. And so I think that's one thing to consider is taking more just to take more is not always the best idea.
Yeah, and I just want to echo that point as well. I forgot to mention it, but all of these domains of quality of life, physical functioning, appetite, fatigue, nausea, vomiting, all the domains are much improved even if we have a little bit of stomach left behind. So we really always try to leave, within good reason, we want to get rid of the cancer. That's goal number one. But goal number two is we want to leave normal tissue behind. And even if there's a little bit of stomach left behind, it helps a lot in the long term.
Can I ask you, Nabil, so how do you counsel patients about the significant changes in diet and how much they're going to eat without scaring them too much? And I'd be curious to see if any of the patients in the audience who've had their stomach taken out, if there's a fine line between informed consent and, oh my gosh, what are you doing to me? Because, I think we all probably see in our office, sometimes the first reaction is, I didn't even know I can live without a stomach. Mm-hmm. And then the second one is, how in the world am I going to live without a stomach? Do you have any opinions about how you counsel patients? And then again, any patients
and hopefully the one of the next sessions on the nutrition and diet would be very informative. But you're exactly right. A lot of the mindset is not knowing that you can live without a stomach. That's for sure. And then we reconstruct it. But how I counsel the patient, I do tell them up front that your diet is going to be changed forever. It's, some things after surgery are temporary. They're going to get better. Some things you can manage, but after a lot of the surgeries we do, including stomach cancer surgery, your diet will be different forever. A lot of that will be a learning process over time. It's not going to be a quick process that you'll be back and up to baseline immediately after surgery. And we have support nutritionists and surgeons and nurse practitioners really experienced in this who can help us through that process. But the goal number one initially is to get enough liquids in and enough calories in, and then make sure you have all the nutritional elements that you need, minerals, vitamins, and things. But frequently, it'll be no large meals. It'll be frequent small meals. That's the one big difference. And the type of food will be altered. And different people have different sensitivities to different things after this surgery. But in general, high sugar foods or very spicy foods, these may not go well. And there are differences between the total and the subtotal, but yeah. And then we same practice at UW. We always have patients talk to nutritionists before surgery as well, and then again immediately after surgery and in the post-operative period, just so that everyone knows what to expect.
Okay.
I think there was a question. Yeah. Sorry, I just want to make sure I got your question correctly. You're saying, are we using team approaches after surgery as well between the different teams? Yeah, I think everything we do is very team-driven, especially at a coronary center like ours. Everyone has their own roles and spaces. We're very specialized. The surgeon and the surgery team are going to look at, they're the overall leaders post-operatively and in charge, but the nurses have their roles and their duties. The nursing assistants have their roles and duties. The nutritionists will come. The pharmacy is always double checking what we are ordering as doctors. So yeah, a very intensive team approach with multiple teams involved.
I guess my question is, are they specialized in gastrectomy, or what to do after?
Yeah, so at high volume centers like Patrick was mentioning, we have specialized floors. Like we have a particular set of rooms where our cancer surgery patients go to after surgery. Patients who are getting chemotherapy before surgery, if they need to be in the hospital, they go to a separate area, which is a specialized chemotherapy area. So our post-operative area for surgery, particularly for cancer surgery, those nurses and charge nurses and students are well attuned to seeing surgical patients and wounds and things. And that helps a lot, like you said, like you can say, people who are familiar with what a drain is, what a fast heart rate means in the stomach patients, and that we have seen that makes a big difference.
I think maybe from what Melanie said, in my experience,
I think I'll say I think we try. So we do. I think one of the things is we do have our own floor. The staffing, like anything, right? People come through, and there's new people all the time, and so we try very hard to have in-services with the staff about different things as part of their education so that they learn all these things. We try to formalize pathways so that even for new people that have started on the team, that there's at least a background for them. And even if someone's new, right, there's someone hopefully on the floor that has seen those patients and, can be asked. But I will say, yes, there can be a disconnect, especially in some things like that. I think we see this not just in gastrectomy patients, but all patients. Our ability to refine what diet is ordered and what the hospital sort of food service will provide is unfortunately a challenge that I don't think many places have sort of solved. We definitely have like a post-gastrectomy diet that can be ordered within the parameters of all the other things that the hospital offers. So I definitely think that's a place where many places that treat gastric cancer patients could potentially do better. And if we ever got, part of it is it would be nice if we could have just a gastric cancer unit, right? Or, but for better or worse, our volume, even at the highest volume centers, right, even at Memorial, don't have just a nursing staff that only sees gastrectomy patients. And so I think that's a little bit of a challenge that we continue to work on.
Yeah, and thank you for bringing, things like that up. Just, I try to mention we're constantly trying to improve and feedback from patients and families and survivors are always important. There's always lots of little things that need attention, and we definitely always have room to improve.
One other point of feedback, since you're open to receiving it, in case we don't get to talk afterwards. You talked about the psychological effect of the surgery, and there was a dip after surgery in your graph, and then it went back up. I found that the first year to year and a half post-TG was so hard. And no one told me just how hard it was going to be. But then, a year and a half later, my energy levels were up, my diet was pretty well established, I knew what I could and couldn't do. My life just pretty much returned to normal. And so did my outlook. Initially, after having the TG, I was like, oh my gosh, did I really have to do this? Like, was this really worth it? And I think maybe being a little bit more real in the counseling up front about just how hard it is would have better prepared me mentally for the challenge. It does get better, but at first it's really hard.
Yeah, and thank you again. For our prehab programs, we're trying to do more of that, counseling and meeting with counselors, and definitely in the bariatrics world, they're more attuned to that, and we're learning from different services. But like you said, and you'll hear from more patients later on in the program today. That's why we're much more particular about who gets a total gastrectomy versus a distal or subtotal. There's definitely a longer recovery period with total gastrectomy and with a lot of other issues.
And I would say there's a balance. So we try to be, this is my own personal practice, but try to be as real as possible about what the outcomes are. But then you kind of got to be real, but be upbeat about it, right? Because you don't want to scare someone about the outcome. Because I think we know that for people who are well selected and know what they're getting into, they will get to the point you got to, right? And we don't want them going in thinking, or not doing something that may be ultimately beneficial. So there is a balance, and how to sort of thread that needle is a real challenge, and is different for every patient. And so that's something that we try to learn how to do with a group of people. And I think preoperative counseling and things helps with that, to find the best way to communicate that to every individual patient.
And I will say that however much counseling happens on the provider side, you can, it's all hypothetical. You don't know what you get until you've had it. And the best thing is organizations like No Stomach for Cancer, where you can use their platforms to talk to patients who've had the surgeries. I think those are the best ways to get the best, I guess, as realistic as possible of expectations. All right.
Next, we'll have Dr. Natalia Boho, who's a leader here nationally in medical oncology for gastric cancer. She'll be talking about personalized approaches to esophagogastric adenocarcinoma.
Good morning, everybody. Thank you so much for organizing this event. I'm a medical oncologist. I was given 20 minutes to talk about some of the updates in systemic therapies, chemotherapy, immunotherapy, and clinical trials in gastric cancer, which is not enough. And also the surgeons, who says the surgeons don't talk a lot? Ours do, clearly. Took 10 minutes from my time, and I am very much aware that I am the last person who stands between you and lunch. So I'll try to be quick, but I do want to tell you a little bit about the updates that have been happening and how we approach patients' treatments with, and I call it esophagogastric cancer, EGA. You'll see this abbreviation, because from medical oncology standpoint, we tend to group actually esophageal, G junctions, and gastric cancer together, so there's some overlap in the treatments. Here are my relevant disclosures. So when we say esophagogastric cancer, or even when they say gastric cancer, it is one name for many different diseases, not only anatomically extending from this area where the esophagus and stomach meet, G junction, but also molecularly. So on a microscopic level, we're dealing with different diseases. And you already heard a little bit about even, the disease in Asia is different from the disease we see in the United States. In Wisconsin, the majority of my patients have actually G junction cancer, which could be classified either as esophageal or gastric cancer. So it could be treated with either gastric cancer type surgery or esophageal surgery. And so it's important to know exactly what you'll be dealing with, because this will dictate the treatments that we can offer. The new drugs that are being developed for the treatment of this disease are not chemotherapy. We're beyond chemotherapy. Yes, chemotherapy continues to play a role, but the majority of research is being focused on drugs like immunotherapy, antibodies that can bind for multiple different targets, antibody-drug conjugates, targeted agents, and cell-based therapies. And I'll try to touch upon some of these and explain what they are, but also tell you about some of the more recent updates and how to approach this disease, both early stage, but also stage 4 disease. So biomarkers is key. For patients who met me in clinic, and some maybe are here, they know that I talk about that we need to characterize the tumor. We need to know what we're dealing with. So this is the cartoon I came up with. This is a normal cell. This is DNA. Tumor cells look different from normal cells. And a few different things can happen. Patients can have mutations in their tumors that can lead to all of a sudden abnormal proteins on the surface of the cells. And we look for those mutations with NGS tests. So when you hear NGS testing, which every patient with stage 4 disease should have NGS testing, we are looking for mutations in those genes because they could tell us what is unique about their tumors. Another thing that can happen, that the tumors can have just exuberant, abnormal amount of the protein that's normal present on the cells, too much of the normal protein. Too much is not good. When the too much applies to this protein called HER2, so some patients' tumors, especially gastric cancer, can have the abnormal expression of this HER2 protein. Or the cancer cell could just look completely different and can have completely different biomarkers. And then the immune cells maybe can recognize these tumor cells, and this is particularly important for when we deal with immunotherapy, and PD-L1 is one of those biomarkers. Or maybe we can just come up with a completely different treatment, completely different antibody that can bind to the cancer cells and recognize it. So knowing these biomarkers, knowing what we're dealing with is important. Another part that's important is to know that the tumor has microsatellite instability. And Dr. Weiss has touched upon this, microsatellite instability. And the reason we need to know about it is twofold. One, MSI-high tumors, or tumors that really lack the proteins that correct mistakes in the DNA. The way I describe it to patients in clinic, when we type, we have a backspace button. These cancer cells don't have a backspace button, and so then they accumulate mutations in their genes. And so the reason we need to know that the tumor has microsatellite instability is because A, it could be associated with the syndrome that runs in the family, Lynch syndrome, although it's much less rare among patients with gastric and G junction tumors. But also this particular subset of tumors is very sensitive to immunotherapy. So it can also dictate what treatments we can offer to these patients. So why is everybody so excited about immunotherapy, and what is immunotherapy? I found this cartoon. I tend to draw this for my patients in the clinic, but I found this cartoon yesterday. So what is immunotherapy? So T-cell immunotherapy is in blue here. Theoretically should come in and kill the red cell, the pink cell, which is the tumor cell. Unfortunately, the tumor cells can have this bat called PD-L1, and it can paralyze or knock off the good T cells. So what immunotherapy is, it's basically a helmet on a T cell. And it protects the T cell from the cancer cells from paralyzing it. Okay? This is what immunotherapy is. It doesn't stimulate the immune system. It doesn't augment the immune system activity. It just prevents the cancer cells from being able to paralyze the immune cells. And so there's a few things that have to happen. I talk about this to my patients in clinic. The T cell has to have a particular, or the cancer cell has to have a particular bed, because if the bed is not PD-L1, if you try to block PD-L1, it's not going to happen. And your T cell has to care that the cancer cell is there, and that also doesn't always happen. So this is the more professional picture of all of this. So again, tumor cell, T cell, PD-L1, when they're bound together, the T cell is paralyzed. And so what the drugs like nivolumab or pembrolizumab are, you might have heard the other names for them, Keytruda or Opdivo, they actually the caps that bind over here and they prevent, they block this way of the tumor cell to paralyze the T cell. So why are we excited about immunotherapy? Well, immunotherapy has been around now for about a decade, and it works very well in some cancers. In melanoma, it's changed the way we treat melanoma. The prognosis is completely different. These drugs tend to be tolerated much better than chemotherapy, and when they work, we see them work for a long time. However, they don't really work very well when used alone in gastroesophageal adenocarcinoma. When they do work, they work primarily in PD-L1 positive tumors, so we have to make sure we know the status, we need to know the biomarker, and they must be combined with something. They don't work well alone. And that's except for these MSI high or these microsatellite unstable tumors I talked about earlier. So with that, what has changed in how we treat patients with, this is stage 4 cancer, so it's a little slight changing from what we've talked about in first line, so people who have not been treated. But first of all, we need to know the biomarkers. And those who have seen me in clinic know, I always talk about we need to characterize the tumor. We need to know what we're dealing with. We need to know HER2, we need to know PD-L1, we need to know microsatellite status, and I always send patients tumors for molecular testing because this next generation sequencing can give us additional information about what we are dealing with. And so this is how we approach it now, and this is a summary. I could have talked about this for like 3 hours today, but I'm only being given 20 minutes, so this is a brief summary. So if patient has a HER2 positive tumor, we now give chemotherapy, a drug that goes after HER2, and we now know immunotherapy. This is an update from literally a year and a half ago. This is new. This study is still actually ongoing, and FDA led to this approval. If the patient has a HER2 negative tumor, then we have to be more nuanced. If there's PD-L1, then we add immunotherapy. If there's no PD-L1, we use chemotherapy alone. And if somebody has MSI high tumors, that immunotherapy must be included. Whether chemotherapy is needed or not is still a question, but that patient, we should really, really think hard about including immunotherapy. And so one theme emerges here. Chemo continues to play a critical role when you treat these patients. And actually the studies were done where, some of the studies were done where they said, okay, we'll take the tumors that have a lot of PD-L1 and we will remove chemo. And what happened, people didn't do as well. Because chemotherapy works fast. And when people come in and people can't swallow or there's a lot of pain, we just don't have enough time for immunotherapy to kick in. So chemotherapy continues to play a role. And so this is a little bit now of a plug about what we are doing at UW. We're running this big trial where we are actually trying to modify the chemo portion of this treatment. We're actually adding another drug to the chemo we typically use because we've known for a long time, 3 is better, 3 chemos upfront is better. We just never been able to do it historically because 20 years ago, the chemo that we were trying to do was too toxic. And so now we're doing a trial where you're trying to tweak the chemo a little bit and add immunotherapy. And so we have, again, this is a trial that's ongoing here, multiple different arms. We pick people's biomarkers based on whether they have HER2 or PD-L1. We add immunotherapy and trastuzumab, but then we also tweak a little bit the chemo regimen. This study is now open here, and also we have partnered with other sites in Wisconsin. What about second-line treatments? So people who have had some chemotherapy, what have been the updates? There haven't been that much updates in the last few years. For patients who have HER2 negative disease, but for HER2 positive cancers, there have been an update, and I do want to talk about it a little bit because there's a completely different drug that we are now using for the treatment of this disease. So it's about 15 to 20% of patients who have tumors that have a lot of HER2. And so as I've showed you earlier, HER2 testing is an absolute must at the time of diagnosis of stage 4 disease. But we also know that HER2 can change over time, and so some patients will lose, the tumors will lose HER2 while on treatment, so it's important to continue rechecking it. And now we have this new drug, trastuzumab deruxtecan. It was approved by the FDA about just close to about 2 years ago. And this is a completely different drug that we use. It's a drug that has an antibody portion with it. So it hooks to HER2, a hook. And then this portion, the bomb, it brings the chemo with it, basically. And so we have a new drug that we can use, and this has been a big change, that we can actually go after HER2 in patients who've had some HER2 therapy in first line. So these are the type of drugs. This is a chemo, but this is a targeted chemo. And this is just an example of the kind of drugs that we are developing for this disease. Now, you've heard a lot about early stage tumors, and you've talked a lot about resection, and so, so just to set the stage, when we see patients with early stage, so stage 2, 3 cancer, we know that we try to treat patients with curative intent. And we know that surgery alone is not enough. Even though you've heard a lot about the details of resection, but resection alone is not enough. And we usually give you the preoperative chemotherapy or chemoradiation for these patients. And the resection with negative margin is an absolute must. This is what will lead to cures. But we also know that patients can recur even after these surgeries. And so the big update in the treatment of these tumors recently has been that we now give 1 year of immunotherapy after resection of esophageal and GE junction tumors. And this is for patients who have had chemoradiations of the GE junction tumors, not gastric tumors. So the question are, what about gastric cancer? Should we be adding immunotherapy to chemotherapy before resection of gastric cancer? And should we be maybe even getting immunotherapy before surgery for esophageal cancer? Those questions remain unanswered. But there's a lot of trials that are ongoing. This is a busy table, but just to give you an idea, there's these big trials, all global trials that are ongoing, and two of them are open at GW, trying to ask a question: can we cure more people with gastric and esophageal cancer if we actually add immunotherapy earlier, before surgery or after surgery? Again, biomarker testing, knowing the tumor is very important. There is actually a subset of early stage gastric and GE junction tumors that have this microsatellite instability. And we are seeing remarkable responses to immunotherapy in these patients. This is rare, but important to check. Even though it's rare, all patients should be checked for it because it could really affect the prognosis and the treatment. And so there was a couple of small trials. This is small font. You don't have to read all of this. One of them is from France, this GERCO Neonipiga trial. 29 patients. Patients had MSI-high tumors, these little rare tumors, treated with immunotherapy, no chemo, went for surgery. At the time of resection, there was no tumor left. We don't see this. Dr. Varley does not usually see this after chemo. So this is remarkable to have 60% of patients after the 2 months of chemo had no tumor left. Another study, this was just presented in January at a big meeting. Smaller study, 15 patients, same thing, just different chemotherapy, different immunotherapy. 60% of patients have tumor left. So we're actually starting to study maybe in these particular patients with these rare tumors, again, it's rare, but you need to check, maybe we can skip surgery. Do we really need chemotherapy? So all of these questions are now being studied in clinical trials. So what is on the horizon? Where are we heading with all of this? I do get this question asked in clinic, even though I'm not a surgeon. Why can't Dr. Varley just cut it out? Right? People, and we used to say, well, if somebody has stage 4 disease, you can't cut it out. But we are becoming even more nuanced about that. We are even becoming more aggressive when we treat patients with stage 4 disease. Because I give patients, I give my line, stage 1 disease, it's in one location. Stage 4 disease, it means the cancer cells in the blood vessels, and they spread to different places. We can't cut it out. But what about this? What about if it's only spread to 3 places? Can we still cut it out? And so we are becoming more nuanced about this. We are starting to think about being more aggressive in patients with this limited stage disease. We are really thinking about each individual patient individually. And now we also have better tools. We don't necessarily have to cut it out. Dr. Bassetti, who I work closely, does amazing radiation. We have SBRT, which is stereotactic radiotherapy, which I call surgery without a scalpel, which can deliver really high doses of radiation to other locations without having to go through a big procedure. And so knowing that you could actually treat multiple locations within the body without the risks of surgery, there's actually, and I'm chairing this study nationally, I'm running a big study, the phase 3 study nationally, that specifically looks at patients who have metastatic disease, but only to limited number of sites. And 3 sites is going to be actually updated to 5 sites. Patients whose disease, whose cancers are behaving and responding to chemotherapy, can then potentially undergo radiation to every site of disease to see whether we can either potentially get more patients to remissions and give people longer time, even though the disease has spread to multiple locations. There's a couple other biomarkers and drugs that are on the horizon. You'll probably hear about these coming up. One of them is Claudin 18.2. Claudin is a gene that kind of helps the lining of the mucosa of the stomach wall get organized, and it's present in the stomach lining, but otherwise it's not present in normal tissues. There is this drug called zolbetuximab. I'm going to call it Zolbi because it's quicker. All the new drugs start with an X or Z. That's how you know they're new. And this is an antibody that basically binds to Claudin, but it also calls in the immune cells. So it's also engineered in the way that it binds to the cancer cells, but it also kind of says, come on, immune cells, we're right here, and attracts the immune system to attack the cancer cells. And so this drug has now been studied in 2 big phase 3 studies. This is new data, which just presented at the big conference. And we found that if you add Zolbi to chemo, and if patients have tumors have a lot of Claudin, they do better, they live longer. I anticipate this is going to be the drug that's going to be approved by the FDA this year. And so you'll have to test everybody's tumors for HER2, PD-L1, MSI, and Claudin 18.2. So this is another one. This is very close to prime time. And there's, I think, about 32 drugs that are being developed that all go after Claudin right now. Another one is FGFR2b. This is just another antenna that's present on the cancer cells. Again, too much is not good. About 30% of gastric cancers and GE junction cancers have a lot of FGFR2. There's a drug that's called bemarituzumab that, same thing, binds to this marker and then calls in immune cells. And when this drug was studied in a clinical study, now this is phase 2 study, so we're further behind with this one. We need larger, really randomized studies. But when this drug was studied in a trial, we actually saw survival. People live the longest we've ever seen in clinical trials. So this is going to be potentially another drug and another marker that we use. There's ongoing studies with this drug. And then the other area that's super exciting is cell therapies. And cell therapies, we've used cell therapies for the treatment of lymphomas, leukemias for years now, but we have not really used them for solid tumors. And what cell therapy is, for those who are not familiar, it's basically we take, or the lab take, patients' T cells, you grow them in the lab, you kind of manipulate them a little bit so that they are taught to really recognize the cancers, the tumor that patients has, and you give them back to the patients, and the idea is that these cells will expand and then attack the cancer cells. We are early in the development of this for esophageal and gastric cancer, but we actually launched our first cell therapy study for esophageal cancer at UW. We treated the first patient, so it's exciting that we're able to offer this to our patients at UW. So the way we offer these cutting-edge and novel agents to our patients is through clinical trials. Clinical trials provide access to novel drugs. A few years ago, I had a patient who was receiving immunotherapy after surgery for esophageal cancer on a clinical study. Now everybody gets it because it's approved. But back then, the only way to get access to these drugs is to clinical trials. Are we always successful? No, but we have to keep trying. And the complexity of these clinical trials and making sure that patients have access really requires a team, and we've put a big team and we have a great infrastructure at UW to be able to do this. I am bragging a little bit about this because I'm very much involved in clinical research. But all of our patients have universal biomarker testing. We have clinical trial navigators who help match patients with studies. We have amazing research teams, and our physicians are very much involved in making sure that patients have access to the right treatments for them. The clinical trial navigators I do want to highlight because this is a new team that's launched just a few years ago, and this is really a team of nurses who help patients within our community, but also from across the state. They have it's a direct line number you can call and say, are there any trials? Sarah Cotilla reads this team. She sends me a message. She gets on the phone with me and tries to find out what's available for the patients and make sure that the patients matched with the right study at the right time. So in summary, there's many novel agents and strategies developed. Biomarker testing, knowing the tumor is critical because the better we characterize the tumor, the better we can tailor treatments for each individual patient. And we have many clinical trials available at UW, and this work would not be possible without our amazing team and collaborators. So I thank you all to all of our patients and their loved ones. You guys motivate me and inspire me to do more, and we know we need to do more. I'm not showing any survival curves. We need to do more, and we will continue. Thank you.
Are there any questions for Dr. Boha?
I'm just curious, what's the latest research on how long one should be on immunotherapy without the PD-L1 checkpoint inhibitor in particular, like Pembro that you mentioned?
So it depends on the setting. You know, for somebody who's had a resection, we typically give it for a year. For somebody who has this microsatellite unstable tumor, we treat for 2 years, and we stop at some point. You know, in somebody has metastatic disease and is responding, and there's no issues with immune checkpoint inhibitors, I don't stop. I tell my patients I don't argue with success. If things keep working and everything is stable, I don't stop. We now have data from some of these studies, like 3 years out, and we have, you know, those like 5% 5-year survivals. Those are they're outdated. You know, these drugs and the targeted drugs, those numbers are going to look very different when we get to the 2 years out. But I don't typically stop immune checkpoint inhibitors in metastatic setting if they keep working.
So you were saying for a stage 4 cancer patient with advanced, like widespread, you should never just be on immunotherapy alone as like a third line treatment. FOLFOX has failed. Irinotecan alone while we were waiting for immunotherapy failed while we were waiting for insurance approval. So now we're just on Opdivo alone, and it's making us nervous because we don't feel like it's enough.
It's not enough. It's usually not enough.
Okay.
There's no approvals for immunotherapy in late line setting for adenocarcinoma, you know, for GL squamous, and I presume you're talking about stomach and adeno.
Adeno, yeah.
And it's not enough because it hasn't worked very well. You know, there's some data coming out from Asia. In Asia, it's approved in late lines. It's a different tumor there.
Okay.
We just haven't seen a lot of activity. It should be combined with something.
Okay, okay. That's what we thought. Thank you.
You know, it's hard to study these approaches specifically for hereditary diffuse cancers because it's so rare. Usually in the clinical trials that are being conducted, hereditary diffuse cancers are allowed, and they are the patients with those diseases participating, but they're not specifically being studied only for those patients. So it's harder to tell. Yeah.
Thank you.
It's lunchtime then.
Yeah, so lunch will be on the 8th floor, and I think maybe can we start again at the 30 minutes from now or 12:40?
Yes, we're a little behind schedule, but we'll move on to lunch. And then actually our next speaker, the nutritionist, Tracy Schmatzer, is our the nutritionist that we work often with on our post-operative floor that we were talking about earlier. Her talk is recorded because she is actually working today. So it's it's a PowerPoint, but it's just the audio of her speaking. So I don't know if we're maybe allowed to bring. We'll start that on time, so people can make their way back down as soon as you're finished with lunch.
It's on the 8th floor?
8th floor, yeah.
Oh, I see.
I can imagine.
And it was just ridiculous. They had to do stuff. It was just nonsense. I learned so much. My mom was diabetic. Dialysis nutritionist.
Yeah.
And I never got from anybody.
I guess that's not so surprising because that is so much more prevalent. There's better studies.
Yeah, they did so much more.
Yeah.
Surgeries, they found out so much more about how much is in the stomach.
Yeah.
But yeah, that's the biggest thing. That's what's kind of really interesting to see what they're going to talk nutrition.
I am so excited that I always find that I've been to a few of these, but I always find that to be the most helpful because it's so practical. It's like, okay, now here's how you get through it.
How do you figure out what they can and can't do?
Yeah.
And the sugar.
Yeah, the sugar is. Tell me about that.
So, like, if you drink like Pepsi, so acid, the acid in it actually bleaches, clogs your bones.
Oh my gosh.
So it needs your calcium. So by the time he passed away, he was barely 50, but he had his bones were like 5.
Wow.
And when he went into bone density test, because he broke first the left hip and then the right hip, and they were just they couldn't believe how they aged him. They left him in check. Kidney patients, they actually start running tunnels with their knees. Because although it's not a great source of calcium for nutrition, it gives something for the vessels to bind to and prevents the leaching of your bones. So the malabsorption, the milk, stuff like that is what he actually ended up, I think.
Wow. Wow, that's so interesting. My nutritionist now does talk a lot about the importance of calcium, but I didn't know.
Yeah, and it did, but it's a big thing. For some reason, the diet with that legal just starts leaching over. And he drank a lot. He got to the point where he worked really hard to tolerate sugar because he traded for carbs.
Yeah.
Because what is it? They're like, you don't drink just one.
Yeah.
It's a waste of space.
Yeah, it's
There's
true.
no calories.
Yes, it's hard to get yourself hydrated. Yeah, you have to make it appealing in some way.
Right, well, and you take up space so that you're not
You can't eat, yeah.
So, yeah, so he never drank any water. Different things to add to it.
Yeah.
Because they thought you had something you could water.
Yeah.
But yeah, that was one of the things I thought was, I think, the most interesting was realizing.
It's so cool that you're here.
Just thought this and was like, oh, I gotta do this.
Yeah. So relevant to your life before. Does anyone else in your family have?
There's rumors that his uncle, his mom's brother, died of stomach cancer, but that was before he even realized that. So he ended up committing suicide.
work on my own. My family was very supportive. My siblings were great.
What's the difference? The choice was
Yeah, I did the biopsies they were talking about. I did 90 biopsies. Once I found out I had the mutation, I did 90 biopsies, and 3 of them had the sigmoid cells of diffuse gastric cancer, and they called it stage 1A. So early. I was so lucky. But as soon as I knew that I had it there, I was like, all right, let's give this
they
a
don't
go.
test early.
Yeah. My dad was prophylactic. He didn't know that he had it, but knew what the percentages were. Once he knew he had the mutation, he was likely he had the cancer. He did the screening, he did the biopsies, they didn't find anything, but then when he took his stomach out, they found that he did have the cancer.
Yeah, I just kind of wondered now. That's what she's like.
Yeah.
She's got a big family.
I wouldn't be surprised if someone else had it. I think it's likely if someone else
It is.
did.
But they're really big cases. They're back. They're really linked to cancer. Of course, it probably had that big diagnosis. Unless they would take more cancer, probably would not have been very different. We were in Omaha. Dr. Tangosha was in San Francisco.
Okay.
And that was her area of specialty.
Oh, wow.
Middle of Omaha.
Yeah.
Not a big cancer.
Yeah.
We were lucky to find somebody like that was her.
That's amazing. So he was an army?
He was Air Force.
Air Force? Wow.
So he was
Mm-hmm.
we were very lucky on that.
Yes.
So he got it on the phase 2 trial.
Oh, wow. Yeah, thanks for being here. Thanks for sharing.
Yeah, so interesting.
I think so too. Hopefully we continue to learn more, keep the momentum moving. Yeah. doing? Are you going for a little walk? Because you're so big. Come over here. Come to Mama. Come here. Come to Mama.
Yeah, you can get down. Go boom. Go boom. Go boom.
Oh, you can do it.
Okay, go down and go boom.
You can do it, buddy.
Yeah, he said I got to try to get my presentation on here. The AV guy said I can't just hook my laptop up. So yeah, I'll join you here in just a second. Yeah.
Check.
wish they would let us have food in here, but.
Hi.
Sure, yeah, I'll probably, yeah, maybe you want to start this within 5 minutes. I can also text John there. I'm just going to wait a few more minutes and then we'll get this started. Let's try to get some people back. Right, welcome back to the afternoon session. I see people are slowly coming back in, so I'm going to start to play the talk on nutrition following gastrectomy, which was pre-recorded by Tracy Schmatzer, our clinical surgical dietitian.
Hi, my name is Tracy Schmatzer, and I'm one of the clinical dietitians here at UW Hospital. Today, I'm going to talk to you about nutrition following gastric resection. First of all, everyone is different. I want to point out that after gastric resection, everyone has a different sized stomach remaining, and some people might not have any at all. Other people may have their GI tracts rerouted because of some intestine need to be taken out, so that may change how they digest food. And finally, some people may not have gastric resection for the same purpose. Some people elect to have a portion of their stomach removed for weight loss. The group I'll be discussing today is a group of people who have had gastric surgery to treat a medical condition. Immediately after surgery, often you can only tolerate a couple spoonfuls of food at once, and that's okay. The important part is to keep eating that small amount of food all day long. We encourage patients to eat by the clock rather than by hunger. So your day might be a few bites of yogurt at 8 a.m., 10 a.m. cottage cheese and peaches, noon, a couple bites of a peanut butter and jelly sandwich, and so on. Protein is the other really important part of your diet right after surgery. Protein in your diet helps your body heal and maintain your muscle mass so you can get out of bed and walk. If you don't eat enough protein in your diet, your body will break down your muscles to help you heal from your surgery, leaving you weak and deconditioned. Good sources of protein are dairy, milk, eggs, yogurt, and nutritional supplements. When looking at protein supplements, try to choose ones that have less than 30 grams of carbohydrates per serving. This means that they have a lower sugar content, which is important when we talk about dumping a little bit later. Some good choices are Premier Protein, Glucose Control Boost, and Fairlife Core Power. General eating guidelines after gastric surgery are eating at least 6 to 8 small meals each day, eating slowly and relaxed, chewing your foods completely before swallowing, drinking liquids or soups 30 minutes before or 30 minutes after eating, and limiting your fluids to 1/4 of a cup to 1/2 a cup with meals so that you don't fill up on liquids without getting any food in. Making sure you get a protein at every meal and snack, avoiding added sugars, avoiding alcohol, and using a food diary as needed if you experience any discomfort after eating, so you can better determine what's causing the issue. So let's talk about dumping. Dumping syndrome is something patients might experience after gastric surgery. Approximately 20 to 50% of patients will experience this. The good thing is that we can adjust your diet and help with symptoms, and often your body adapts with time, and this no longer is an issue. Early dumping happens about 15 to 30 minutes after eating. You'll feel nauseous, you may vomit, or have cramping diarrhea. This is thought to be caused by osmotic diarrhea. What that means is that all those little food particles in your stomach get dumped into your small intestine because you don't have that bottom valve on your stomach to control the release of food anymore. All that food in your small intestine is not normal, and it causes water to rush into the small intestines, causing it to swell, and then the cramping and diarrhea begin. Now, late dumping happens about an hour later. It's when your body reacts to all that food in the intestines, so it sends out a bunch of insulin to absorb it. The problem is, you've already pooped out all that sugar and food by the time the insulin gets there, and the insulin overdoes it, causing a low blood sugar, and you start to feel shaky, sweaty, and flushed. So, strategies for dumping syndrome. Small frequent meals, and that's important because that means less food in your remaining stomach means less food in your small intestine. Making sure you separate liquids from your meals to prevent the food from washing out even quicker into your small intestines. So drinking 30 to 45 minutes before meals and waiting about an hour after a meal to drink a large amount of liquid, again, to prevent that washing out. Avoid sugar and alcohol, as this increases the transit time in your GI tract. You can do sugar-free drinks and foods. They're usually well tolerated. Increasing fiber and fat intake, because these two things in your diet actually help food stay a little bit longer in what remains of your stomach. It slows down the emptying, actually. And then rest and reclining slightly after eating can be helpful because movement increases GI motility. And if we want to kind of keep things calm and relaxed, just take a little siesta after you eat. And finally, limiting lactose if those foods seem to be associated with diarrhea and cramping. So a common issue after surgery is nausea. Tips for managing nausea: avoiding foods that are rich, spicy, or greasy. Don't eat or drink too fast. Try putting your fork down between bites. Don't have too much to eat or drink at one time. Don't lie flat after meals, waiting 2 to 3 hours before lying down. Fullness is often a problem because your stomach is smaller after surgery and it fills up faster. So again, not eating or drinking too much at one time. Don't drink too much liquids with your meals because that will really fill you up. Don't eat or drink too fast. Again, a good rule of thumb is putting your fork down between bites and remembering that it takes about 20 minutes before your brain realizes that you're full. If you're having trouble, have 6 smaller meals instead of 3 larger meals, and actually create a schedule where you're eating, setting time for eating and drinking. And if you find yourself going back for larger portions that you used to eat before surgery, try making mini meals or pre-portion the meals ahead of time so you're cutting back on those amounts. Avoid carbonated drinks such as soda and seltzer. Those bubbles can really make you feel full and gassy. And avoiding vegetables that make you feel full and gassy, such as broccoli, cauliflower, cabbage, Brussels sprouts, and beans. The fiber in those can make you feel really full. And finally, some tips to manage diarrhea. First, try eating less sugar, then try less dairy, and then try less fat. And pay attention to see if the diarrhea gets better when you cut back on any of these things. If it does, try to eat less of those foods. Avoiding sugar alcohols like sorbitol and mannitol. These are used in gums and hard candies, some cakes and cookies as well. And you can see if a product has these by checking the ingredient list. It's okay though to use other sugar substitutes such as NutraSweet or Equal. Try eating foods with more soluble fibers such as canned fruits, bananas, peanut butter, and oatmeal. And make sure you're keeping food safe at home, putting leftovers in the refrigerator or freezer right away, throwing away refrigerated leftovers after 2 days, throw away frozen leftovers after 6 months, and thaw your frozen leftovers in the refrigerator or microwave, not in the kitchen counter, and make sure you reheat them to a safe temperature. Next, we're going to talk a little bit about nutritional deficiencies. Because your GI tract is different, you're at a higher risk of being deficient in some vitamins and minerals. Vitamin D is a common deficiency in any Wisconsin resident, and the prevalence is about 25 to 80%. So recommended supplementation is 3,000 IUs daily, and the goal is to maintain that vitamin D level greater than 30. If you have a deficiency, you're going to want to replete with 6,000 IUs daily or 50,000 IUs weekly. You'll notice one is D3 and the other one is D2. For thiamine, deficiency is highly variable, and recommendations after gastric surgery is 50 to 100 milligrams daily. And you can get this from the B complex that we recommend you take after surgery. You'll see that at the end of the recommendations. If your levels are low, though, you're going to want to increase to 100 milligrams twice a day until those symptoms resolve. B12 prevalence is about 33%. So the vitamin B12 needs acid to be absorbed, and often this is low after a gastric resection. So the recommended supplementation is 350 to 1,000 micrograms daily via a variety of routes, as you can see there: orally, intramuscular, sub-Q, nasal spray. If you test low, you're going to need 1,000 micrograms until your lab values return to normal. Folate, 400 to 800 micrograms, and you can get that from your daily multivitamin. If you end up having a deficiency, you're going to want repletion of 1,000 micrograms daily. And then iron, 18 milligrams, which you can get from the multivitamin, and repletion if you're low is 150 to 300 milligrams 2 to 3 times daily. So how often should we be checking labs? Well, recommend checking 3, 6, and then annually after surgery, but make sure you discuss with your physician on your individualized schedule, because like I said, depending on your anatomy, your vitamin and mineral levels can vary. If the resection was real small, you might not need any sort of monitoring. If the resection was quite big, or you needed some intestinal rerouting, you're more likely to have be at a higher risk for deficiencies. So here's a summary of what you should be taking. General recommendations are children's chewable multivitamin with iron twice daily. Lots of people like the gummies, but no gummies. The gummies don't usually have any iron in them, so you want to make sure you're doing like the Flintstones or the generic one. The sublingual B12, 350 to 1,000 micrograms daily. Vitamin D, 3,000 IUs daily, and then adjust depending on your level. Iron, you'll be getting in your multivitamin, but if you're low, you're going to want to add ferrous fumarate or ferrous gluconate, 325 milligrams daily, and adjust that depending on your level. And then take a B complex daily. Just make sure the B complex has one that's got about 50 to 100 milligrams of thiamine. So eating in the future, most patients can gradually increase their food tolerance. Dumping usually resolves with both diet modifications and as your GI tract starts to adapt. And most patients get back to eating a general diet with normal portion sizes. So I hope you found this presentation helpful. Thank you for your time.
Are there any questions from that presentation from the audience that I know Tracy's not here with us, but that I could potentially answer? Go ahead.
Okay, now it's on. It looked like some of the vitamin levels could return to normal, like the B12 and the vitamin D. Does the iron level ever return to normal, or is supplementation something that might always be the case?
Iron deficiency is variable after gastrectomy, and women are more susceptible to it because they have lower total body iron stores to begin with. From my practice, I usually tell patients beforehand that, we will follow your levels and see if you need supplementation rather than, because not everyone does. Some people are still able to absorb enough iron from food. And taking oral iron, as you may know, can cause a lot of GI-type side effects, particularly constipation and just generalized discomfort. And so what we do sometimes also for patients who become deficient in iron is IV iron infusion. Some people prefer that as opposed to taking it by mouth because of the lesser symptoms and because it lasts for a long time. Then you generally don't need to worry about supplementation again for quite some time. Any other questions? Okay, next on our agenda is patient stories, and I think we have Brad Fisher has very kindly volunteered to share his experience with us. And when he is done, if anyone, again, we can open up a forum for discussion. I know there's many patients here today, and so if anyone would like to share their experience or talk, all right.
Can you hear me okay? Well, good afternoon. My name is Brad Fisher. I feel like I've done different presentations and I've introduced myself different ways, but this is odd because I'm introducing myself as a cancer survivor, cancer patient, certainly proud of that, but I also don't want that to define me. I guess I'm much more than that. So, I'm proud to be a husband, a father, I'm an uncle, all kinds of things. So those of you that are in the room that are cancer patients, cancer survivors, I know you're much more than that as well. In terms of my cancer diagnosis, I was diagnosed in 2018, June of 2018. So there's so many memories like flooding into my mind as I've been sitting here listening, and so many, thoughts of where I was, where I am now, and then sort of questions on where I will be. But yeah, in 2018, I was diagnosed with gastric cancer. At that point, it had already spread, it looked like, through the EUS and other tests throughout my lymph nodes. We had different conversations of options that we were looking at, but all the options felt like they were slim and not very, very good. But I started on chemo, went on immunotherapy, and here I am today. I'll kind of connect the dots there a little bit as we go forward. But certainly what I'm remembering most is this issue of control that I felt then, probably still now. And I guess a better way to say it is this loss of control, feeling out of control, how everything in my life felt out of control. So when I was thinking about what message I can share with you, I wanted to talk about what I've learned, I guess, about the issue of control. And certainly one of the things that felt out of my control was my health was quickly deteriorating, and again, the options didn't feel good. Even after I started on chemo, I started having these weird lesions that start popping up throughout almost like my gastric tract, like on my chin, my neck. So not only internally was it spreading, it was spreading externally. So my health was quickly deteriorating, and that felt out of control. But it actually wasn't even like the thing that I felt most overwhelmed with. It was like how it was impacting every part of my life. And certainly front and center in that was my family. I have two daughters. At the time, the one was 13 and the one was 11. My wife, but even my extended family, suddenly what their new normal was definitely not what their lives had been before. But I had all the other practical things. My job, professionally, by the way, I do data analytics for an educational technology company. But yeah, there was everything from appetite to my hopes, my dreams, how both who my friends were, but also how my friends viewed me. Certainly money was a worry. And identity sort of jumps out, and that's even why I wanted to sort of introduce myself here, not just as a cancer survivor or cancer patient, but to say those other things, because I felt like in an instant, everybody saw me as the cancer patient, which I hated that. I honestly did. I hated the gloom and doom that it brought with it. But my interest, my personality, how I spend my time, and how much time I have left suddenly felt out of my control. It felt like it was in the control of, this beast that I called cancer. And actually, I didn't even call it cancer. So what I did was I started writing, and I took a screenshot of this. It's not that active anymore, by the way, but it was a blog, and I couldn't even call it cancer. Still this day, it's not like, I know it needs a word, but just the word, I had so many people in my family who had died or suffered and died from cancer, and I just felt like I'm not that guy. That's not me, so I'm not calling it cancer. And so I just made up a name, honestly. I called it cat sores, and you're like, why cat sores? I'm like, well, it sounds enough like cancer. People knew what I was talking about, but whimsical enough, whereas it was almost this just annoying ailment that I could talk about that, but it became like, these cards, people rallying, giving me support, all these great people in my life sharing, they're praying for my healing of cat sores, which, made me laugh and certainly brought me peace as well. So I started writing the blog. The inspiration, I guess I should say, behind it was my two daughters. Again, as I mentioned, this is Anna Mae and Elizabeth in the book, and I'll talk about it. This turns into a book here eventually. But in the book, we call her Lizzie, because that's what we call her now. She's old enough, we call her Liz. So Anna Mae and Liz, I'll say, that's my wife, Tanya. But my inspiration was the two daughters, and certainly what I wanted to do was leave them with, I guess, lessons. And again, at the time, I did not think I was going to certainly be here, going on almost 5 years from now. I thought my days were very much numbered, and so that was like a way for me, I think, to take control, to be honest, but also felt like a way I could have a voice to their future. So bear with me here. I'm going to tell one of the stories in the book, and I know this is not in the medical journals, so bear with me. But one of the first posts I made in the book, and I'm like trying to build into this. I don't know if there's a safe way to do this, but this is what I called it, all right? So it's called Shit Purse. Like, forgive me, I'm just gonna say it. So the story is about this childhood game that I used to play, or middle school, I think I was in middle school, that we used to play. And it's a ridiculous story, and in case you didn't have the worldly upbringing I did in southern Indiana, and you're not familiar with this game, let me sort of lay out the fundamentals of it. You need two ingredients to play the game. You need a farm animal, I guess manure is a better word. And the second ingredient, anybody want to guess the second ingredient? Purse is purse. Purse, you need a purse. So ingredient one goes ingredient two, and I won't go through in great detail, but just to give you a feel for how this game played out is, again, middle school boys, we'd throw this purse on a road by my friend. My friend's name, Craig, was my mentor, I guess is the word, on who taught me this game. But we would basically hide and sit and wait and watch for cars to pick up this purse. And, what we longed for was this perfect mix between, basically what the perfect outcome was if the purse got picked up, got in the car, the person got back in the car, then we'd see it shoot out like a rotten apple core, basically out the window. And we would laugh. Now, that didn't always go exactly as planned. Like sometimes people would stop and they'd get out and they would look in the purse and then, just drop it. And sure, we'd laugh, that was funny, but that wasn't as funny if it shot out the window. So we called that, or thought of that as kind of a premature purse drop, if you will. Sometimes the purse went into the car and the person started driving down the road and actually just kept on driving. So then, we were sort of left to our own imagination of it shooting out the window. And it also ended without us having a purse. So, whereas if it shot out the window, the game continued because it was repositioned for the next round. So I share that story in my blog because it really was sort of this issue of control. And so Craig, who I mentioned, didn't just teach me this idea of the game, he also taught me about perseverance and so much more. You see, Craig lost his dad when he was 5 years old, and they lived again on a farm, and Craig's dad was the guy that, ran the farm. He was Craig's hero, And just from a practical matter, I was only 5 years old as well as Craig. I remember when Craig died, or excuse me, when Craig's dad died, everybody thought, they're gonna have to sell the farm and there's no way they're gonna make it. And, long story short, not only still to this day, Craig is my friend, but I'm proud to say he runs that farm and he's now, the hero to his kids, much like his dad was to him. So this issue I wrote about because I guess what I early on realized, I felt like suddenly this person in the game of shit purse. I felt like I was the victim now, where I'm holding this bag of crap, literally, where the stench, cancer was in my life, and I felt like the victim. And at the time, as a middle school kid, I thought of these people picking up the purse as these greedy people that wanted to pocket a few bucks. As an adult, I realized they're probably the kind considered people just trying to get somebody their purse and their money and their identity back. But at the time, again, I didn't see it that way, but now, during my diagnosis, I feel like the victim. So what I guess I chose early on is this issue of control, is that yes, cancer had made its way into my life, and yes, it may dictate the length of my life, and yes, there are so many things I cannot control. But there are things that I can control, and all the stuff that comes with it, I'm just gonna choose to throw some of it, as much of it I can, out the window. And that's been sort of my message from that story, but again, in sort of continuing to think about cancer, is I cannot control all of it, but I can control some of it. What I've also learned is there's a big difference between control of cancer and control with cancer. So I don't control what all happens with the cancer, but I do control, or how it, if it metastasizes, where it metastasizes, but there are things I still can control while I have cancer. And I want to kind of highlight just 3 of those categories, I guess, if you will, of control. So number 1 is I alone control how I think about it, my attitude, basically. And, I realize, or I don't fall in the camp that a positive attitude alone is going to get you through it. And I almost sort of, I don't want to say I resent it, but so many people are like, just stay positive, Brad, just stay positive. I'm like, I don't think you know how bad it is. So I don't want to be just naive to think that a positive attitude gets you through it. But I also realized my 2 daughters were watching, and they're going to learn something from this, right? They're going to learn something from this. And so I may not, be able to control the outcome, but I hope they learn a lesson about how to deal with any adversity, I guess, in life. So this is what I control, is how I think about it, my attitude. The second category, this is a we. I'm going to just say my medical team as a whole, that's my doctors, my oncologists, my family, and I control how we treat it. And I guess the key word, in addition to treat, is like the team in this word. And there are so many people that I could sit here and just give shout outs to, but again, I'm from Indianapolis area. This is Paul Health, my oncologist, but I just had a team of amazing doctors working with me to go at this. And I was trying to think, what do I all share about them? But I think the easiest way for me to boil it down on why I felt like they were the perfect partners in my care, and I guess what I would say if doctors are listening here is what would I say from a patient perspective, things to consider. That's sort of what I want to highlight. So these were 3 things that Dr. Health said to me. And I'm going to just go through them. As number 1, I remember I think it was maybe my first appointment with him, when I met him. Again, I'm a data guy, and I was asking all kinds of questions, but I remember him pause, and he just says, very sort of factually, how much do you want to know? And I don't think I realized at the time how important that question was. And he even, I remember, explained, he's like, well, here's the thing. Some patients do better with less information, that they really are better when it's just sort of boiled down, like here's what you should do, and too much information is just noise and overwhelming.
But some patients do better being prepared and want to know options and want to know information. But at the heart of the question is control, right? He's letting me control what I want to know. And I get he has to make professional decisions. I get that. But, he asked me, and I said, I'm one that does way better, and I really feel like I am, when I know what to expect. I want to know as much as you can, and I also want to know as many options as possible. I'm a data guy, so I want to know like the percentages of those options. I think it bugs me to think I'm making the wrong choice, so I want to be as informed as possible. So that became sort of the way our conversations continued, is he would allow me to ask a lot of questions. But it all began with him simply asking, how much do you want to know? A second thing I want to highlight that he said more than once is, I want to check with my colleagues on this one. And the reason I like that is, and again, I'm sure every patient is different, but I wasn't looking for someone who had all the answers or the keeper of all the information. I was needing a partner and help me find the best path forward. So although, I think he's considered he is considered a national expert, and there were other doctors like Douglas Rex was the gastroenterologist. I know he's known across the country. I wasn't just impressed on what they knew. I was impressed that they considered themselves as a part of a community, that they considered themselves a learner themselves. So that was one thing that I loved about that partnership, is him being willing to admit what he didn't know and being willing to say, let me check with other doctors. And also I think goes with that, he would often ask me, not my thoughts on human anatomy. He knew very quickly I wasn't at his level, but he would sort of like ask, he would allow me to question his logic, I guess, around decisions. He didn't take offense to it, he encouraged it. So number 3 was simply, what concerns do you have? And I love this question, and it's certainly like, how are you feeling and all of that, but what concerns do you have? And that could go so many directions, and just like all doctor's appointments, we had typically 15 minutes tops during my appointments, so it's not like we had these deep philosophical conversations, but I felt like it did allow me to share what I was most worried about early on. And I won't, again, be the gloom and doom guy, but truthfully, what I was most worried about wasn't necessarily even, dying and suffering. I guess it was this idea of being a burden. Like, I hated the thought of lying in a bed and getting treatment even after all hope was lost. So I needed to know that he knew the power of medicine, but kind of the limitations of medicine, and that he would know my concern is like what my wishes were. And again, we didn't have these deep philosophical conversations, but the question, what concerns do you have, I think opens so many conversations. So here I am, after 2 years of treatment, ringing the bell. So I had 12 rounds of chemotherapy and 32 rounds of immunotherapy. So again, I was mentioning I was having this flashback when some of the other speakers were talking. So I was, or am, PD-L1. They were able to check the cancer for the genetic mutation. So as I was on chemo, again, it was continuing to grow, but I was able to get, long story on this, but insurance to finally cover immunotherapy. I went on the commonly known as Keytruda, pembrolizumab, is what I went on. I was on it for 2 years and had this amazing response, just amazing response. That to the point of after the 2 years, because throughout this I was not only getting regular scans, but I was getting different scopes. But by the end of the 2 years, they did both the upper and lower scope, and everywhere the tumor had been, I almost like paused because I always feel like, I don't even know the right words, but it had literally vanished. It was no longer there. There are only signs of it like throughout my esophagus, and the original tumor in my stomach was just like necrotic, basically scar tissue. It was nowhere to be found. So just an amazing response to it. Now, I will say that's not completely how the story ends. This is me then, about a year and a half after I went off, and I guess what would now be about a year and a half, maybe not even quite a year and a half. This is October of 2021. The same form of cancer came up in my brain as a large tumor in my brain, and so had that surgically removed. Surgery went well, and also at that time there was always this mystery on my lymph nodes because they continued to remove different lymph nodes and biopsy those, and it was a mixed bag, I guess, of what they were seeing. So they removed another lymph node, and then this time actually found 2 other forms of cancer, diffuse large B-cell lymphoma and also follicular lymphoma. So I honestly don't know how the story ends, I guess, just to be blunt about it. This is where I am today. What I realize, I don't control that, but I control how the story gets told, I guess, a little bit. And so I am proud that throughout that blog that I was writing, again, I really just wanted 2 copies for my daughter in a book form. So I worked with an editor and somebody, a book designer, and basically published it myself. And it's called The Sand Bucket List, and again, it's hopefully these lessons that serve my daughter, but I've been amazed on how it's sort of spoken to a lot of people. I'm not here to push the book, it really is not my point, but if you do feel like it helps someone, it's on Amazon. I have those that are here at the conference, there's some out there. But again, it's truly to tell my story of what I hope can benefit others, and how others can learn both from how I thought about it, but also from the amazing doctors and medicine that I received. And so that kind of brings me to the third category of control, is I feel like we all control, as a global society, I guess, how we tackle this disease as a whole. And it's what impresses me so much about this group, and the speakers here today. I didn't know about this organization, should have known about this organization, but I'm just so impressed. And if I had a wish, I wish the auditorium here was full and standing room only outside, and I wish the servers would go down of people watching it online, because again, truly I believe knowledge is power, and knowledge shared is power multiplied. So thank you, I guess, to everyone that's come for being here. If I had to make a wish, and I feel like I could get way into the weeds on this, so I'm trying to keep it short here, Brad. But if I had to if I could snap my fingers of what do I feel like as a patient, and I'm going to emphasize this is as a patient, because I feel like I'm not understanding. Well, I know I'm not understanding how this works. But I guess I want to talk about what I've benefited from, and then also what I feel like are some issues that I feel like are gaps on how we, again, as a society, can tackle this. So I know this is hard to read, and don't feel like you have to try to read it, but this is my original, I guess, personal touch with cancer, in terms of I had friends and other people who had cancer, but I knew more than 25 years ago, I put the date up there, but 1997, that I had what is now commonly referred to as Lynch syndrome, so the MLH1 gene. I knew I tested positive, and I guess I will highlight sort of I don't know if this makes me more important here, but I want to point out who it's from. It's from Dr. Lynch. So the weird connection here is my mom, again, 25 more years ago, had, her dad passed away of colon cancer, but then she had, at the time, 3 brothers with colon cancer. I may be mistaken, but I think 1 had just passed away, 2 actively fighting colon cancer. And they were being seen down in just Evansville, Indiana, but actually Henry Lynch, again, now it's commonly referred to as Henry Lynch, came to their hometown where they were, encouraged people, particularly my mom's family, with this predisposition to colon cancer to get genetic tested. My mom did. She met with Henry Lynch, and turned out she was positive. And so when she was tested positive, our Christmas present that year was a kit to get tested, and we actually 2 of the 4 of us kids were positive. And I joked that was a Christmas present, but on hindsight, it was like one of the best gifts I was getting, or was given, because it I really feel like I am the benefit of this because I am convinced. I've had colonoscopies every year, pretty well, I mean, at least every 2 years, but almost every year, and upper scopes because of this. And without knowing this, I know I would have gotten cancer, colon cancer for sure, long ago because I've had polyps removed in my early 20s. So I really believe information is power. My wish, just to come back to that, and I guess, certainly I'm a big believer of genetic testing. I wish it was easier, more streamlined for patients to do it. I wish, again, insurance wasn't a barrier for some of these screenings. I certainly wish and applaud the knowledge sharing that's going on here. This is me making the point of empowering patients. My whole thing is I want to give as many tools as possible to empower the patients, but honestly, the doctors too. So you could substitute me there for a doctor. My hope is that we can make it easier. So forgive me, this is a rough mock-up. I said I'm a data guy, and you spent 10 minutes on this, but I almost wish cancer research and contributing to cancer research was more like buying a car online. And so I was asking one of the presenters earlier, I was asking how long should somebody be on immunotherapy? Well, again, that's been my question, to be candid, because I was on immunotherapy for 2 years, I went off, and then it came back. But it feels like such a mystery behind the curtain, and what I wish it felt more like, and again, I know there are databases out there, it just feels too hard. Like, I want to pull the lever that says, let my information be available on some national database. Now, remove my name, don't attach it to me personally, but how does my story help the next patient? And so what I wish also from a searching point of view, I could just search and say, I want to see all the patients with gastric cancer who've had a positive response to immunotherapy, who have Lynch syndrome, and do my own sort of research. And it feels so mysterious on how to get to that answer. I am sure it's out there. I'm sure there are tools out there. Part of this is just showing my own ignorance. But in case it's not my own ignorance, and there is somebody listening to this that can solve this, this is my wish on how we as a society, I feel like using data has to be more efficient somehow to get at the heart of this. I'll end it there. I'll simply say thank you for your time. This is me representing time, because it is the most important and most difficult decision, I get it, we make every day is how do we spend our time. So the fact that you're here, you should pat yourself on the back. Thank you for letting me ramble, tell my stories. I would be glad if I can help anyone. This is my name, some of my titles I share. Contact information I did, again, just recently just put up a website myself. It's a pretty basic website. That's my website. That's one way you can contact me. You're also welcome to just email me at Brad M. There's an M in there, Fisher, and there's a C in Fisher, just to point at gmail.com. So I certainly would love to help however I can. Thank you so much. I'll be glad to take questions.
Thank you so much
Thank
for
you.
sharing your experience. And I think, go ahead.
I'd like to thank you, Brad, for sharing your story. I mean, I think it's important for people out there to hear that and hear your experience. So it's not easy, and I just thank you on behalf of everyone who treats and has gastric cancer and all cancers. So one question I have is, and I think it goes to the idea of control, and one thing I talk to patients about, but I still don't know the best way to put it sometimes, is that no part of cancer or cancer treatment is easy, but in a way, it seems sometimes like the initial phase where we are doing things in some ways, or at least mentally a little easier, because it feels like we're doing something, and that sometimes the survivorship piece, once we're all done with that, is maybe even harder, right? Because it feels like, okay, now what, right? And you sort of have to move on. We try to help people move on with their life. after cancer, hopefully, and sometimes that becomes a little more challenging. So how did you navigate that in the time where you sort of, like you said, we're done with immunotherapy, and you're like, okay, so I've done all this stuff, now what do I do?
Boy, I may be the wrong, I love the question. I recently was asked, did you have the, and I don't even know if this takes the direction you're even asking about, nor do I feel like this is the medical doctors to wrestle with, but somebody recently asked me, did you have the feeling of why me? And, you know, obviously I did have a little bit of that, but it was more for me like, why my family? Like, that was the question that I wrestled with during my diagnosis. But I will say, and again, I won't make all of you my counselors in here, but when I had a positive response, you would think I was just a positive response to immunotherapy. You would have thought I was because I felt like the luckiest man in the world, and yet, honestly, that is when I started feeling why me. I had this still, I'm gonna get choked up talking about it, but still this like heavy weight of feeling like, why do I benefit from this? Because I have seen firsthand and known firsthand people also, in fact, there was a young lady I never met, but when I was asking where I was being treated, who had the same deal, basically. She was in her 30s, younger than me, but who was on immunotherapy, gastric cancer, had metastasized, started everything the same, and she had no response to it. So it's part of the reason, like, I almost want the data, because I feel like, how can we learn? Why did she not and why did I? So to your question is like, what happens, you know, after treatment? I mean, just know that it's there. I guess I would say this to the doctors, is that this is as much a head game as it is a physical thing. And you know, I truly, like, it wasn't just worrying if I was gonna make it. It was after I felt like, oh my gosh, I'm the beneficiary of this, but oh my gosh, this does not feel fair at all. I know that doesn't help, but that's just being real with you to give you perspective of what I think, I'm not gonna speak for all patients, but what I carried with me. Did I don't know if I even went the direction you're
You did.
yeah,
I think
okay.
that's not something that there's all those things that go into it, and I think that's a really unique insight into how we help people feel like it's okay to be happy about what happens
Yeah.
to them, right?
Yeah, or go the opposite. Again, I won't get too much into this, but another thing that Dr. Health, and again, I want to be careful here because I think this could be bad advice to doctors to go out and say this, because I don't think it would be received the same by all patients. But I remember early on he said something like, and again, this is not a quote, but something like, Brad, you know, we're all dying. It's just that everybody else lives under the illusion they're going to live for a long time. And again, that's probably a lot of patients would be like, not respond well to that, but honestly, there was some peace in that it brought me, of like just thinking about mortality. And again, not I get it from a doctor. You can't sit in an office for 15 minutes and have philosophical conversations, but I think both understanding life and death, there's something there that I think matters, to know how somebody not only wants to live, but how they want to die as well. Yeah.
Thank you so much.
Thank you.
We will still have more, I think, time at the end too for more open discussion, but I think we will move on with the presentations. Oh, mine was open here already. So with my presentation, I kind of wanted to, in a way, summarize. I know we've heard a lot of information today from people in the different aspects of cancer, gastric cancer treatment and experiences. And so I actually changed my slides a little bit during the course because seeing what other people showed and presented. But so I really want to summarize in some key points in the staging and treatment of stomach cancer, and then talk a little bit about novel surgical techniques, as that's my part in the treatment, and novel diagnostic and surveillance aids. So the approach to gastric cancer that I teach to our trainees and that I kind of learned back in fellowship, and not just gastric cancer, but any cancer, is we want to name it, stage it, and treat it. We've talked a lot about the way that gastric cancer is diagnosed today, which is usually by endoscopy with biopsy. And historically, that has one of the first pieces of information we get is the subtype, the intestinal type or diffuse type. And now, with recent advancements, we also really want to know that microsatellite status at diagnosis. As Dr. Uboha mentioned before, that treatment can be totally different, based on these different subtypes. We then want to stage it, which is by the CT scan of the chest, abdomen, and pelvis. Dr. Pfau mentioned is usually the best first test because that shows if there's metastatic disease that we can see on the scan, and then that makes some of those other tests maybe not be necessary. And then if not, the endoscopy with ultrasound, which looks at the T and N stage, and then the staging laparoscopy, which is really something I feel strongly about and is really recommended for most patients with stomach cancer in the United States if there's not evidence of metastasis on CT scan. And that's, again, because we don't screen, and so it's rare that we catch it very early. And then treatment is really the key things are the multidisciplinary review and plan, so that now that we know more about the molecular subtypes, that we can come up with a formulation of a comprehensive treatment plan that's as individualized as possible. And we've repeatedly, many of the talks today pointed out the importance of being treated at a high volume center. And I want to talk a little bit more even about why that is. So focusing on the surgical standards in terms of the surgical treatment of stomach cancer, which was nicely kind of summarized by Dr. Varley and Dr. Zafar earlier. These are some of the standards that have been put forth in particular in this. I have a picture of this Operative Standards for Cancer Surgery manual. This is a publication put forward by the American College of Surgeons, and it summarizes the key steps in cancer surgeries that are thought to directly impact oncologic outcomes. And gastric cancer was included in the second volume of this publication. And this slide and the next show some of the surgical standards. And one is, again, the staging laparoscopy with peritoneal washings, partial gastrectomy for cancers of the lower or distal portion of the stomach, and total gastrectomy for proximal cancers. Now, that's a little bit now coming into possibly changing, and I'll talk about that more in a moment. Minimally invasive surgery is a suitable alternative to open surgery, and especially for early stage disease is becoming more the standard of care. R0 resection should be performed whenever possible, which is, again, microscopically negative margins, so removing the disease completely to microscopically negative margins. And then what's really called a modified D2 lymphadenectomy, which is clearing those lymph nodes along the major arteries going to the stomach. With, again, as a means of trying to measure that, it's recommended that at least 16 lymph nodes be removed in a gastrectomy for cancer and examined. But if you really read the fine print of the NCCN guidelines, it's more like 30 lymph nodes is considered optimal. I'll explain why this says evaluable and non-evaluable in a moment, but these are some of the additional surgical standards from the manual. So I, in a previous study, sought to look at, are these things being done, nationwide? We assume that, I think a lot of times patients assume when you're going to get certainly a surgery or treatment that it's going to be done the best way possible in accordance with guidelines and be a high quality endeavor. So I looked at using the National Cancer Database, which is a national oncology outcomes database that receives data from over 1,500 different hospitals in the United States and also Puerto Rico that are hospitals that are Commission on Cancer accredited. And we looked by the data points collected in this, out of the surgical standards for stomach cancer, these are the ones that kind of could be measured or assessed. These were not, and these three are not things that are measured in the database. And when we looked at this, we looked at patients who underwent gastrectomy between 2004 and 2014 and found that actually of the stage 0 or 1 patients, only 36% met the minimum surgical standards. And out of patients with more locally advanced disease, stage 2 or 3, 44% met the minimum standards. Now, those numbers are not great. And you can see in the table here, the biggest driver of non-compliance was the lack of the staging laparoscopy being done at baseline. The rate of R0 resection was actually pretty good. And then also the extent of lymph node dissection, which is basically in this database measured as the number of lymph nodes examined, was also suboptimal. So just to talk a moment more about staging laparoscopy, this is a little video that shows this procedure, which is a surgery, but it takes about 15 to 20 minutes for the most part. And we put a camera and usually just 2 trocars in the abdomen. We look around at the peritoneal surfaces. So this is the body wall up here, this is the liver. And if we don't see anything to biopsy, we just put in some saline and rinse it around and suction it back out. And then the pathologist looks at that fluid and sees if there's any free-floating cancer cells. And that's very important information to have, because if there are, we know that just going ahead with standard treatment, like just surgery certainly, and here's lifting the liver, and this is the stomach below the liver. But proceeding with just surgery, even if someone's tumor looks like it's just early stage, it's not going to help that patient. They're going to develop peritoneal recurrence. The peritoneum, which is the space in the abdomen where the stomach sits, is the most common site of metastasis from stomach cancer. And so it's not to say, if this result is positive, it's not to say that there aren't treatment options, but that going ahead with, early surgery certainly doesn't make sense. Sorry, I'll move on to the next. So sometimes what happens when patients don't have that done and then say they get referred, they get chemotherapy before surgery, and then we go to do the gastrectomy, and this happens commonly because, as you saw, staging laparoscopy is not performed very consistently throughout the country. We might find something like this. This is a picture of the peritoneum, and this is part of the falciform ligament going up to the liver, and you can see this tissue looks kind of abnormal here. This is like my least favorite situation to face, because once someone's had chemotherapy, even for just a couple of months, we can go biopsy that tissue and it'll likely come back as just being fibrosis or scar tissue. But you don't know. We have no way of knowing. At baseline, was that cancer? And now should we go do this big total gastrectomy right now when, is it going to benefit the patient? And if they didn't have the laparoscopy at baseline, we don't know the answer. So we're potentially doing a big operation that might not provide the types of outcomes that we and our patients are expecting. And then on to the lymph node dissection. This is a video that I made in my... Minimally invasive gastrectomy. Sorry, I don't want to do the volume. That I just want to show you a little clip of this. This is a video that I made with some of my former partners that we presented once at a conference, and it just kind of shows the lymph node dissection, I think. I'm going to go right to about this point that we do. And, this is really kind of arguably the most sort of dangerous part of the operation, and that's why the compliance rates when we look at a large data set like the NCDB are low, because the lymph nodes sit along with major blood vessels. So what you're seeing here is the common hepatic artery, and we take this dissection over to where the artery goes up into the liver here. This is the left gastric vein or coronary vein that we clip and divide. And so this tissue that we're holding up is all fatty and nodal tissue. Like when we do an operation, I can't tell you at the end how many lymph nodes did we remove, because we don't really see them that discreetly. We learn that information in the final pathology report when we get that final pathologic stage. So this is just completing that, and then we divide the left gastric artery, which is the largest named artery to the stomach, which you're seeing right here. So getting all of this, it's possible to remove the stomach or do a gastrectomy without doing this step and getting all of that nodal tissue. And that's what's done, in some settings where perhaps people don't do a lot of gastric cancer surgery or are not as familiar with the current guidelines. So going back to this same study from the NCDB, when we looked at survival outcomes, these are survival curves again of patients who did or did not meet those minimum surgical standards. We see that the red lines, the patients where the surgical standards were met, have better survival. And this is what we call a univariate analysis, where we're just looking at that factor, but in this study, even when we controlled for specific stage and other factors that can affect survival, meeting the surgical standards was an independent predictor of better outcomes. So one more study I just wanted to talk about. From that information, we went on to say, well, why are some of these things not being done? We can speculate as to why that is, but we created a short or brief change package to give to lower volume centers and have them, it was an activity for them to do. It consisted of a pre and post video quiz of just 5 questions, an informative video on gastric cancer staging and treatment, which was just 10 minutes long. And then we provided a discussion guide with a questionnaire about organizational readiness for change. And we advertise this to Commission on Cancer Accredited Hospitals because we know that they have a tumor board, and we wanted this activity to be done at a tumor board. We then analyze the results to try to understand barriers to performance of some of these steps in gastric cancer treatment. And this is the link. The video is actually still available from this change package. And so we didn't have great participation in this study, but we had 7 centers participate. And you can see here that most of them, or a few of them, treat under 20, they estimated under 20 patients with gastric cancer per year. And that's not just, that's not even surgeries, that's just patients in general with gastric cancer. And these are the number of participants in the pre and post quiz at each site. But this was the quiz results, so I don't have to go over each question, but these were things that we covered in the video, and you can see that the percent correct is the pink, and the percent incorrect for each question is the blue. And so things did improve after watching our video, but unfortunately still weren't 100% correct, even though these topics were covered in the video. And then this table, the thing to draw your attention to is the reasons that were reported for why some of the standards and things were not being done at these centers. And one that we see frequently is the lack of availability of surgeons skilled in the D2 lymph node dissection. And then another common one was too few gastric cancer cases per year to have a dedicated multidisciplinary team. So shifting gears then just quickly to what's new in surgery. I know we talked about gastrectomy earlier, and I was going to go on to discuss proximal gastrectomy. Historically, when we see tumors in the upper part of the stomach, total gastrectomy was recommended and still is a lot of the time, especially if the tumor is locally advanced and has spread to lymph nodes. But more recently, proximal gastrectomy has been revisited. This was something that used to be done. This is a kind of a rough drawing of the upper half of the stomach being gone, and this is a new connection to the lower half. Now, having this be the esophagus and connecting it to the lower half of the stomach is just not possible sometimes because there's not enough reach. This portion of the intestine is fixed in place by the pancreas and connections to the liver. So people used to do this with a segment of jejunum, of the small intestine, that would be attached to the esophagus up here and then plugged into the remainder of the stomach. We don't really recommend doing this, and the reason is that this lower portion of the stomach doesn't work anymore, at least not right away after we've removed the upper portion, and that's because the vagus nerves that innervate the stomach come down from the top down, and so when we take out the upper portion, this part doesn't work. It's kind of just rigid and doesn't move. So the outcomes from this operation, even with the jejunal interposition, were not very good. But once again, from the east, where we have the high incidence countries, they're all kind of always a little more advanced in things, and they've described this procedure of proximal gastrectomy with double tract reconstruction. So now we remove the upper portion of the stomach, but do the regular Roux-en-Y reconstruction that we would normally do for a total gastrectomy, but you reconnect that antrum or lower portion of the stomach to the side of the bowel here. And then people can still eat right away, and just like if a patient had a total gastrectomy, the food goes down the small bowel, but over time, this portion of the stomach does regain some function, and food can go this way and can still go through the duodenum. And that's where, so this portion of the stomach and the duodenum are critical for normal B12 and iron absorption. So results from primarily Eastern, more high incidence countries are showing that the long-term, digestive functional outcomes of this operation are superior to a total gastrectomy. So this is being done for proximal cancers that are localized. And we have even done some of these here at UW. This is another brief video that just highlights this procedure, and I know we're kind of running out of time, but I also wanted to show, along what's new in surgery, that when we do this procedure, that portion of the stomach, we still did the division of the left gastric artery and removed the lymph nodes. So that little remaining portion of the stomach doesn't have tremendous blood supply anymore. Here it is. This is the antrum that we're about to reconnect to the roux limb. And we can use indocyanine green, it's kind of to assess how well the tissue is being perfused. So it's a fluorescent agent that we give IV to the patient, and then with our cameras, we can turn on a fluorescent filter and see if this tissue is getting good blood supply and is going to be healthy and hopefully heal well and not have problems with healing at the new connection. So you can see in this case that it is perfusing, turning green, and has good blood supply preserved. What's new in detection and surveillance? There is a pretty exciting publication that came out recently. This is a table from the National Comprehensive Cancer Network guidelines. I did make this table in 2020, but I checked and these guidelines are still the same. That for patients with hereditary diffuse gastric cancer with a known pathogenic alteration of CDH1, that prophylactic total gastrectomy is still recommended. So, but now this study was just published from the NIH hospital in Bethesda, where Dr. Davis, who I think many of you know, reported a prospective cohort of 270 patients with pathogenic or likely pathogenic CDH1 gene alterations. And they followed these patients for a median of 31 months at this point. And 120 of the patients elected to forego prophylactic gastrectomy and have endoscopic surveillance. And in those patients who had 2 or more endoscopies, 74 of 76 developed occult gastric cancer, which is basically a finding that we think nearly all patients with hereditary diffuse gastric cancer syndrome have, meaning carcinoma in situ or non-invasive high-grade dysplasia are different words for that. In only 2 patients in this prospective study who elected against gastrectomy, so for 2 out of 120, developed during that time a focal lesion that was more advanced than basically T1B. And both patients developed T3N0 gastric cancer. So basically the rate of developing that under endoscopic surveillance was only 2%. And they also reported of patients who did undergo gastrectomy who had negative endoscopies, 39 of 42 did have that occult gastric cancer finding, which is kind of consistent with the population that did not have a gastrectomy. And so what's being proposed in this study is for patients who undergo endoscopic surveillance for this syndrome, who have random biopsies of the stomach, so no gross lesion identifiable, even if it's positive for that carcinoma in situ or early, very early stage finding that's not yet invasive cancer, that rather than undergoing prophylactic rather than undergoing a total gastrectomy at that time, that it may be reasonable to just continue with surveillance endoscopy, but at a shorter interval, at 6 months. So this study may be, this is very new, like published this month, so this may be, leading to a change in those NCCN guidelines and recommendation for prophylactic total gastrectomy. And then also new in gastric cancer treatment is studies looking at the role of liquid biopsy, or what we call circulating tumor DNA. We talked about this a little before, and this is relatively new. A lot of the new clinical trials for stomach cancer are incorporating checking ctDNA at various points to really determine its significance. And this is a study I was involved in previously, where we had a series of 55 patients with esophageal or gastric cancer. Most of them had metastatic or stage 4 disease. And the rate of having some kind of detectable circulating tumor DNA was 76%. And then not only can ctDNA help to show, that cancer is present, but it can also identify specific mutations and help to characterize it in addition to tumor biopsy. This slide Dr. Ubo had given me previously that just kind of illustrates some of the potential roles of circulating tumor DNA in gastric cancer treatment. This is a figure from a commercially available assay for multi-cancer detection. So this is when a person doesn't have a known tumor at all. It's just a blood test that can be done. And it just highlights down here for stomach cancer that this is very new. We don't really know if this will have a role as a potential adjunct or in addition to endoscopy and early detection. This is their validation cohort of this assay, and there were only 6. You probably can't see it so small, but there were only 6 patients with stage 1 stomach cancer, and ctDNA was detected in 1 of 6 patients. And then as the disease became more advanced, the rate of positive findings on this assay went up. So we don't know if this will have a role or not yet. We're kind of low on time here, so I will cut over that and just go to the summary points that regarding circulating tumor DNA. It may have a role in early detection and diagnosis, and then also in potentially guiding therapy and detecting minimal residual disease after therapy. In conclusion, progress is being made in all aspects of gastric cancer treatment. High-volume centers are really critical to receive the best and most current standard of care therapies and optimal comprehensive care. Comprehensive staging at baseline is also critical to making a sound treatment plan, and multidisciplinary treatment is needed for most patients in the United States due to stage at diagnosis. There are many studies underway to better understand the significance of liquid biopsy or ctDNA in detection and treatment. My last slide was just as a segue to our next talk. I remember when this publication came out in 2014. I had just finished fellowship, and forever we had only talked about the 2 histologic subtypes of stomach cancer, and this was so exciting at the time to have these molecular subtypes. And so we've talked about CDH1 quite a bit and microsatellite instability. Our next speaker, Dr. Johansson, is going to talk about Epstein-Barr virus and its role in stomach cancer. He is a associate professor of medicine here at UW, specializes in infectious disease, and is a member of the Carbone Cancer Center.
Thanks. Are we full screen now? That probably?
Yeah.
Brilliant. And then how are you changing the slides? Like just with that?
I was just hitting or clicking. Yeah.
All right, great. Thank you for that kind introduction. I have to say, as Caitlin said, I'm an infectious disease doctor, and so I don't treat gastric cancers. And I've learned a tremendous amount from my colleagues and from Brad's stories, and so I'm really humbled and grateful to be able to tell you a little bit about something that I do know about, which is Epstein-Barr virus. I don't have any commercial interests to declare. I will briefly talk about some non-FDA approved uses for drugs towards the end, and again, I'm an infectious disease physician, so I'll rely, if you ask me any tough questions about gastric cancer per se, I'm going to rely on my colleagues to step in and answer those. It may come as a surprise that viruses cause cancers, but in fact, we've known for about 100 years this is true, and that was with chickens. But it's only been since the early 60s that we had our first human tumor virus, and that's my virus, Epstein-Barr virus. And subsequently, over time, we've identified an increasingly large number of viruses that are associated with various cancers. So the hepatitis viruses cause liver cancer. We know that papillomaviruses cause cervical cancer and head and neck cancers. It's been a while, and maybe we're finally plateauing here in terms of our discoveries, but we think that approximately 10% of human cancers are attributable to viruses. And so the little bit that I'm going to talk about today, I'm going to give a little bit of background about Epstein virus per se as a means of understanding why it might cause stomach cancer. Talk a little bit about how EBV-associated gastric cancers are different from others. And then address the important question of, like, is EBV really a driver here? Is it actually causing cancer, or is it just along for the ride? Talk about whether or not there are any useful screening and therapeutic implications of this virus-associated cancer, and then finally, the issue of whether or not antiviral drugs, which we have a lot of, are going to be helpful to us. So in terms of background, EBV is probably best known for causing mononucleosis, the kissing disease, very common among college students, also military recruits. Fever, sore throat, swollen lymph nodes, people get pretty sick for a period of weeks, then they fully recover. But what they don't do is lose the virus. So EBV is a herpes virus, and you remain infected, and in fact infectious, for the rest of your life. And so asymptomatically, probably 95% of the people in the room have EBV and are shedding it periodically in their saliva, but almost none of us are ill. And so the virus life cycle, it enters through the oral epithelium, and that's why we get the bad sore throat initially, but it actually spreads its way to the B cell compartment and in fact infects B lymphocytes, the antibodies that are responsible for making antibodies. It then can reactivate from that, spread back to the oral epithelium, and that's how it sheds. And so the reservoir is really the B lymphocyte, but the oral epithelium is a critical part of its spreading to other hosts. And critical to this is this ability to alternate between two types of infection. And so herpes viruses undergo latent infection where they aren't actually making copies of themselves. They just sit inside the cell and they can essentially hibernate for decades, but then periodically reactivate and spread to other hosts. And it's one of the reasons why herpes viruses are so incredibly successful, is because when they're in this latent phase, they're almost completely invisible to the immune system, so you can't eradicate them. What's interesting about EBV is that most viruses actually cause disease during the phase that they're replicating. And this is true for other herpes viruses, and it's true for almost every other virus. What's unusual about EBV is that it actually causes harm in its latent state, and it's because it can express some genes when it's sitting here in the nucleus. I don't know if I have a pointer. Can we see that? Oh, brilliant. So these little circles inside the nucleus of the cell are actually the virus. And like any other, it's a DNA virus, and like any other piece of DNA in the nucleus, it can express genes. And the genes that it can express in latency promote growth of these cells. And normally the immune system keeps this under control, but with certain environmental or genetic cofactors, this can get out of control and be associated with cancer. And critically, our drugs, and this is sort of leading something I promised to talk about, or hinting at something I promised to talk about later, our drugs are effective at treating viral replication. They're not good at treating latency, and this presents a problem for treating EBV-associated cancers. All right, that's the bad news. The good news is, although a huge proportion of us are infected with EBV, almost none of us will develop cancer. So we've been through this sort of collective trauma of a virus entering our population, and that was COVID, right? And so when viruses first enter the human population, they can be very dangerous. They're not well adapted to us, and we're not well adapted to them. Over time, viruses that kill hosts quickly don't do well, and so they tend to get outcompeted by ones that are less dangerous. And likewise, the people that are most susceptible to a virus may not survive that initial pandemic. And so as time proceeds, viruses that are established in the human population become less and less dangerous to us. And so a very small number of individuals will ever develop EBV-associated cancers. And so, however, EBV is still, as you can see, responsible for a significant number of annual deaths, both in terms of lymphomas and epithelial cancers or carcinomas. But that's largely because we estimate that there's probably almost 5 billion people infected with EBV. So there's a huge exposure here. And it's not just merely the number of people that are infected, it's the fact that once you're infected for life. And so although it's a very weak carcinogen, there's very substantial exposure to this virus. Okay. The other thing that's really interesting about Epstein-Barr virus is that what takes it out of that balance is different in different populations. And so we see very different cancer manifestations of Epstein-Barr virus around the world. It was actually originally, and so here's some different, so in industrialized countries, Hodgkin lymphoma is one of the most common manifestations of EBV-associated cancers. In Asia, it's nasopharyngeal carcinoma, and in equatorial Africa, it's Burkitt lymphoma. And it's in fact Burkitt lymphoma where the virus was initially discovered. And that actually sort of presents an interesting story. Burkitt lymphoma is named after a missionary surgeon named Dennis Burkitt, who was working in Uganda. And when he got there, he noticed that children in Africa developed a tumor he'd never seen before. And it was characterized by these really large masses that developed in their jaws. And he had a pathologist that helped him determine that, in fact, this was not a sarcoma as they initially thought, but in fact, a lymphoma. And he wrote a grant to the UK, and I believe it was funded for a total of £10, which was just enough to buy postage for him to send letters to all the other missionary surgeons around Africa and he wrote a case description of this tumor and asked if they were seeing it. And it allowed him to create a map that showed that this lymphoma that eventually became called Burkitt's lymphoma mapped almost perfectly onto the malaria belt. And that led to the hypothesis, they knew that viruses were spread by mosquitoes, led to the hypothesis that maybe this was a virus-associated cancer that was being spread by mosquitoes. That turned out to be exactly half right. So it turns out that it was a virus-associated cancer, and it did lead to the discovery of Epstein-Barr virus. But in fact, it wasn't spread by mosquitoes at all. When we really began to study the prevalence of EBV, it was shocking that everyone had this cancer-causing virus, almost everyone. But it turned out that malaria was a critical cofactor for why in sub-Saharan Africa, the virus manifests its ability to cause cancer as Burkitt lymphoma. We know less about what we know less about why it causes Hodgkin's disease and why it causes nasopharyngeal carcinoma in other instances. And that's sort of an important unmet knowledge that we need to work on, is understanding why this virus causes different cancers in different locations. Now, as far as gastric carcinoma goes, EBV positive gastric carcinomas follow the prevalence of gastric carcinoma around the world. So areas that have more stomach cancer have more EBV-associated cancer, and the percentage that are EBV positive are highly consistent. However, there are some striking differences. So just like gastric cancer is more common among men, EBV positive gastric cancers are more common among men, as well as, and less prevalent, therefore, among women. There are other interesting aspects of the epidemiology. It's much more prevalent in non-antrum portions of the stomach, And so the cardia and the middle of the stomach have higher rates of EBV-associated cancer. And it's also very highly increased in gastric stomach cancer. So individuals that have had portions of their stomach removed for benign reasons, for reasons that we don't understand, are at increased risk of EBV-associated gastric cancer. And then, as was, I think, alluded to previously, there's an unusual histologic subtype called lymphoepitheliomas, where the cancer is highly infiltrated by immune cells, and a very small number of actual epithelial cells, which are the cancer cells. This has a much higher rate of EBV positivity, something like 80%. And this dark stain here is actually stains for the virus. And all of these other things are infiltrating immune cells that are actually trying to kill the cancer cells. All right. And as Caitlin mentioned, this study, this is a figure from the TCGA paper that really, I think, convinced the field that this was not just a coincidental association. Because as I think you can sort of get an appreciation here from this methylation data, the EBV associated cancers naturally clustered together as their own distinct entity. So this really appears to be a different disease than the other gastric cancers. And similarly, when we start drilling down on the actual mutations that are associated with it, it has a very distinct mutational profile. So there are very specific mutations in the host that cooperate with the virus to cause cancer. It's funny, we know a lot, even though, as you may remember from one of my earlier slides, much fewer lymphomas are associated with EBV, and the burden of cancer is actually much higher in epithelial cancers. We know a lot more about how EBV causes lymphoma, and this really speaks to how important it is to have good models for us to study anything. So one of the peculiarities about Epstein-Barr virus is that when you infect B lymphocytes with EBV and then try to grow in the lab, they become immortalized. They'll live forever. So we can make anyone here live forever if we just take some of your B cells, infect them with EBV, and then put them in tissue culture. They'll grow and grow and grow and grow. And the reason they'll do that is that we've taken away the immune system. So the immune cells that would normally, when you become infected with EBV, prevent this from taking over, aren't there in tissue culture, and we get an immortalized EBV infected B lymphocyte. We see parallels to this in highly immunosuppressed patients. So this, in our organ transplant patients, where we have to highly suppress the immune system in order to protect that transplanted organ from being rejected by the immune system, those individuals are at much higher risk for EBV-associated lymphomas. Our understanding about gastric cancer is much less sophisticated, again, because we don't have models to study how the virus is transforming the cells. Now, this is a study that was done in my lab where we took normal oral keratinocytes, which are not stomach cells, but they have many aspects of their biology that are similar, and we infected them with EBV. And what we saw was that we got a disruption in the normal differentiation of the cells, just as a result of latent EBV infection. So the virus is not making copies of itself here. And then it also dramatically disrupted some of the keratin that's expressed in these cells. So just this virus sitting there in the nucleus, not making copies of itself, is dramatically rearranging these cells. And finally, DNA replication, which is normally restricted to the lowest level of an epithelial layer, was happening in suprabasal layers. And then also we see a little bit of invasion of these cells into the collagen media. Just go through this quickly. So just one of the things that we found when we actually looked at the gene expression in cells comparing differentiation to EBV infection was that although EBV infection did not dramatically change the effects of differentiation on gene expression of these cells, it did attenuate them significantly. And that parallels what we saw in these tissue culture. So we see that the viral infected cells still differentiate and form that nice surface layer, but they don't do it as well. And that's exactly what we saw on a genetic level. And what we think is going on in these normal cells is that the virus is latent in these basal cells. And so this is a normal epithelial layer. And as these differentiate further and further, the cells actually progressively become less and less metabolic to the point where you've got this surface layer that is essentially dead husks. And that's the protective layer on any skin surface of an epithelial layer. That's not useful to the virus, because what the virus wants to do is make copies of itself and release itself at this surface layer. And so part of what EBV has evolved to do is prevent this differentiation from going quite as far. And you may have heard of cancer being a state of de-differentiation. And so we think that part of the normal life cycle of Epstein-Barr virus is to slow and attenuate this differentiation, and that's probably part of the reason why it is promoting transformation of gastric cancer cells. All right. And some open questions are what EBV gene products are doing this inhibition of differentiation, and what role of EBV impaired cell cycle exit is important in carcinogenesis. All right. How am I doing for time? I'm okay? All right, a few more minutes. Addressing the idea of whether EBV is a driver or a passenger, I want you to consider for a minute the challenge this virus actually faces in trying to persist in a cancer. So if we look at these EBV genomes that are sitting in the nucleus, if they don't replicate and make copies of themselves before this cancer cell divides, they're going to dilute out, and ultimately most of the cancer cells won't have the virus in it. So that's one thing that the virus has to overcome if it's going to participate meaningfully in causing cancer. It has to trick the cell into making copies of itself as the cell divides. The second barrier that it faces may not be obvious at first, but once you enter mitosis and those two daughter cells start to come apart, the chromosomes will get pulled in opposite directions into the new nucleus. And EBV is tiny compared to those chromosomes and doesn't have the centromere that normally tethers the chromosomes to the next cell. And so it's actually at risk of getting left in the cytoplasm and destroyed. EBV, for reasons that I don't have time to get into, EBV has solved these problems, and so it tricks the cell into making copies of itself, and it actually hitches a ride on the chromosomes to try to stay in the nucleus. And it does this pretty well, but it's not 100% efficient. And so over time, the number of EBV genomes in a cancer cell will decrease, all right? And so if it's not making a meaningful contribution to that cancer cell, as the cancer divides and divides and divides, it will eventually lose EBV. But that's not what we see in EBV-associated cancers. They're EBV positive. So why is that? Well, what happens is there's selection for success. And so you'll see here, in this instance here with this cell division, we duplicated these two and had 4 copies, but instead of going evenly to these two daughter cells, one daughter cell got 3 and another daughter cell only got 1. And what happens in EBV-associated cancers is that the more genomes that you have, the more successful that cancer is at dividing. And so the fact that a cancer is EBV positive, based on these first considerations, actually tells us that EBV must be contributing to something because you are selecting for its persistence. All right. What's it contributing? We know that the number of genes that EBV is expressing in gastric cancer is actually quite small compared to what it expresses in lymphomas. And we think that one of the main things that is going on is that it has genes that are impairing the differentiation state of those. But then the other thing that it does is it expresses a number of viral microRNAs. These are tiny pieces of RNA that actually shut down genes. We don't fully understand the targets of these, and that's an important area for future research. All right, in terms of screening and therapy, so one of the questions I get asked is, should we be looking at our gastric cancer patients for their EBV serostatus? Should we be testing to see if people are EBV positive? Or the flip side, I know that I am EBV infected. Should I be worried about stomach cancer? I'll remind you that almost everyone is infected by EBV. And so a consequence of that is there's not much utility in doing that test, right? Because it's almost certain that you have the virus. And what we really need is a better understanding of what the cofactors are that make it dangerous for causing stomach cancer. So there's not much utility in testing for EBV infection. There is more utility in testing the actual tumor to see if it's EBV positive because that has implications for treatment. All right. And so those implications are that often the EBV-associated tumors are more receptive to immune therapies. You saw all those immune cells coming into the EBV-associated tumors, trying to kill them. If we put those hard hats on the immune cells and protect them, they will become more effective at killing these. So EBV-associated cancers are good targets for immune therapy, and so it is worth knowing if the tumor is EBV infected. EBV has other reasons for carrying a more so the prognosis is favorable for EBV-associated cancers compared to others. It tends not to be the diffuse type. It tends to be a more localized mass, so more often it's able to be resected. And it has, for reasons that I don't understand, a lower incidence of metastases. All right. And then finally, this idea of using antiviral drugs to treat the cancers. You may have appreciated that because the virus is in a latent state, our drugs aren't going to work. However, there is interest in seeing if we can use the presence of the virus in these tumors to kill them. Because when you flip this latent to lytic switch and turn on replication of the virus in that cell, that one particular cell is going to die. And so if we can come up with ways to efficiently turn on that replication of the virus, we could essentially make these tumors self-destruct. There's a couple of problems with this. Our ability to turn it on is pretty inefficient, so you can only kill a very limited number of cancer cells. And then the other problem is we need to have ways of controlling viral spread to other cells, or otherwise that would be somewhat self-defeating. So these are things that we're interested in doing, and there are actually trials going on that combine the use of antiviral drugs plus this reactivation, but those are very much experimental. Yeah, like here. So this sort of kick and kill strategy is being investigated, but it's not ready for prime time. Try to turn on the replication of the virus and use an antiviral drug to prevent spread. Okay, so yeah, this is my last slide. So I just want to summarize what I've tried to tell you. So how is EBV-associated gastric cancer different? It's different in terms of the tumor location and histology. It has a male predominance, which is actually similar. It has a much more favorable prognosis, and it has a distinct mutation profile. I hope I've convinced you that it is in fact a driver. It's an important participant in the cancer process. And so at some point, if we develop an EBV vaccine, it's going to be interesting to see if we see a rate in gastric cancers due to EBV drop. The screening implications are limited. Serology is certainly not helpful, but definitely determining whether the cancer is EBV positive is useful. And at the moment, there's no defined role for antiviral drugs. So with that, I'll be happy to take any questions, and thank you for having me.
So with the development of an EBV vaccine, do you think it would be marketed as like an anti-mono thing? Because if we're all walking around with it, how are you going to convince people?
Right. So for that's the most obvious endpoint for an EBV vaccine is reducing the rate of mono, and that's actually not trivial because there's a lot of days lost of work. A lot of people have a much longer recovery from mononucleosis. And in fact, we did have a vaccine trial a couple of decades ago that did reduce the rate of mono. It didn't prevent EBV infection, and so people still acquired it, they just didn't get as sick. And so I forget which company developed that vaccine, but they decided that was not going to be commercially viable and didn't move forward with it, so we don't have a commercially available EBV vaccine, but there's a lot of active interest in making a better one that hopefully, I think there's enough evidence to say it's going to prevent mono. The real question is, can we reduce the rates of infection, get them down from that 90, 95%? And that's an open question. Yeah?
When you do an endoscopy, you find a cancer, is it typically tested for EBV, or is that something you have to go and ask them to retest the sample for?
Yeah, it's not routinely tested for, but now that we're doing generally more molecular characterization of cancer, I think that's where we're learning that more.
Yeah, I can't, thank you. I mean, I would think that if you saw one with that heavy lymphocytic infiltration, that's more likely to get tested because the rates are so high in that subtype. But
I had a question too.
Yeah.
I'm guessing the answer to this is no, but we've seen the kind of worldwide geographic maps today of gastric cancer incidence, and then you were just showing of those other more better characterized EBV-associated cancers. Is there any clear geographic pattern of EBV-associated gastric cancer that we know about?
So it's unusual in that gastric cancer with EBV seems to be incredibly flat, that the percentages don't vary in the same way that all, and so whatever the risk factors are that are predisposing to EBV-associated gastric cancer, they're much more sort of even across the globe. Clearly male sex is a huge risk factor, but we don't see the same sort of environmental or genetic factors that are so obviously creating different prevalence for other EBV-associated cancers. All right.
Thank you so much.
Yeah.
Yep. We are now kind of, it's 2:30 in our period of our closing kind of session, or, and so if there's any more general questions or comments, or anyone who would like to share an experience or anything, we're kind of open for general discussion now. All right. Well, thank you so much for attending today. This was a great opportunity for us, and it's very nice to meet and hope to meet more of you later.
Yeah, I just want to remind everybody that we're getting together at the Spring Hill Suites up the road for food, beverage, and fellowship. Get to know each other, tell some more stories. If you have any questions for the organization, our board members will be there as well. So it's a good time, social, casual, low-key. So love to have you there.
Thank you.
Thank you. Too bad it.